Start with the second session, and our first speaker is Dr. Paul Robertson. I met Dr. Robertson first in the 1980s when I was a fellow at the University of Minnesota. He by then was already the chief of endocrinology, a distinguished professor, and he did studies in pancreas and islet patients that I hadn't even heard of before. And he was working with his team of fellows from all over the world, really, at the CRC at the time. And many of the things that were generated in the 80s and 90s in Minnesota really were the basis and foundation for our current understanding of islet and pancreas transplantation. And when we talk about islet transplantation, meaning both auto and allo-transplantation. Obviously, I mean, he didn't sit still. After he left the University of Minnesota, he became the president in the Seattle area, where he used to work also as a faculty member at the University of Washington. He became the president and CEO of the Pacific Northwest Diabetes Research Institute for 22 years, for a long time. He traded in the Minnesota cold for the Seattle rain, but I believe all in all, he enjoys the rain better than the cold, Paul. I hope that is fair to say. Dr. Robertson has an extensive bibliography with over 400 peer-reviewed publications in some of the most prestigious journals that exist, over 300 published abstracts. He consistently has received NIH support and grants from other prestigious federal and non-federal institutions. As I said, he has been the mentor and teacher to many endocrine fellows that are now themselves in leadership positions throughout the country and outside of the United States. He was the editor-in-chief of Diabetes for almost half a decade, and also the editor-in-chief of other journals. But he will be probably most recognized for his work in pancreas and islet transplantation, because I think it's fair to say that no one else in the endocrine field has taken that type of interest in what started in the 1970s in Minnesota. And Dr. Robertson, along with his predecessor, Dr. Frederick Goetz, really put Minnesota with David Sutherland on the map in terms of what our current understanding of this type of beta cell therapy is. So I'm very much delighted to welcome Paul Robertson to us today, and he will talk about endocrine function and metabolic outcomes in islet and pancreas transplantation.
Well, thank you, Rainer. It's just a pleasure to be here and see all you folks following carefully what Rainer's doing. The purpose for me to be here is just basically retrace a lot of the things you've heard this morning, but from a metabolic point of view. So it's been my pleasure to inherit the patients that have been transplanted by the surgeons, and then to ask the question, what were the outcomes metabolically? And it worked great. So beta cell replacement, this is just a primer from what you've already heard, just to remind you that there are many ways to replace the beta cell. There's pancreas transplant, partial pancreas transplant, pancreatic or islet transplant, and with the subgroups I'm showing you. So many of the generalizations do hold, but there are subtle differences between how much pancreas you put in, how many islets you put in, and where you put the islets, I think, more importantly. So those are some of the things I'll touch on. So let's look first at pancreas transplant. The success rates in terms of beta cell function, alpha cell function, and secondary complications. Now, to be thorough, I should remind people that the beta cell makes insulin, the alpha cell makes glucagon. There may be people here who don't know that. And the secondary complications that I'll talk about are the ones that were mentioned earlier. The tissues get adversely impacted by hyperglycemia. So pancreas transplant, typically the donor, the brain dead donor who donates that pancreas, gets the pancreas put into the recipient's pelvis. The native pancreas is left alone. Most commonly, this is done in combination with a kidney, so the SPK, simultaneous pancreas and kidney transplant. This is an older slide that shows the exocrine drainage from the pancreas going into the urinary bladder. Things flipped in favor of the bowel now, so now the exocrine drainage goes into the bowel, so that both tissue types in the donated pancreas is used. Survival rates. So these are survival rates, both of the patient and the organ. SPK, PAK, and PTA were the three different types of pancreas organ transplant: simultaneous pancreas and kidney, pancreas after kidney, or pancreas alone. Survival rates for the patients are shown in red and green, and it's always been about 95%. I mean, some patients do die, but it's usually not of the surgery. It's a perioperative death. It's probably due to the diabetes more than anything else, because in a long period of time, it would not be surprising to see 5% of a diabetic population dying. So we don't think this is a killer operation. In terms of the organ survival, it's best if you give a simultaneous pancreas and kidney. It's not quite as good if it's a pancreas after kidney, and not quite as good PTA. There are reasons for that that are speculative, but probably not important for us to get into today. But it's very good. If you can transplant an organ and have it be really active out to 3, 5, and I'll show you some 10-year data soon, that's considered very successful. Over time, of course, success has increased. This is a comparison on a slide given to me by Andy Pilsett. If you look at 120 months post-transplant, 50% survival is shown by the gold bar. That's 1987 to 93. There's a light blue one there. It's a little above that. There's kind of a, I don't know what color that is, pink and red. So it even continues to improve today. And I think there'll be more comments later in these talks about where survival is for organ transplant in terms of longevity. Fasting glucose levels. This was the most impressive slide when we got the data back that I can imagine even talking about. These are fasting glucose levels. Of course, pre-transplant, they're all very elevated, but they just drop like a rock. If we had 6 months data, this would be showing that the levels get into the normal range immediately. It's just amazing that you could take a group of patients with type 1 diabetes. This is their glucose control, and if you transplant a pancreas successfully, you wind up with really normal glucose levels. To me, the most impressive comparator for the recipients is the hemoglobin A1c levels as reported by the DCCT. This is a long-term diabetes control trial, and it comprised of a standard therapy, what we called at that time intensive insulin therapy, and we were delighted when we got levels of 7 by treating people more intensively with insulin. Well, here comes pancreas transplant on the scene, and it does much better than we can do with all the tricks we can imagine by giving insulin therapy. These are older data, 1991 comparison for the DCCT. I think with today's therapeutic methods, which have improved, that we can get levels even lower than this. But the price of it, unfortunately, in a type 1 diabetic, if you get lower hemoglobin A1c levels to the normal range, you're also going to get hypoglycemia. We don't want that. That's more dangerous than the difference between 7 and 6 for hemoglobin A1c. So most of us treating patients are very happy if we can get them at 7%, particularly as the patients get older. It's just not safe to be trying to get elderly people down to 7, so we're settling for 7.5, sometimes 8. But the point is that pancreas transplant, because it does turn on and turn off, it's responsive to what the glucose level is. And that's different than if you're armed with an insulin syringe or an insulin pump that's not closed loop. You have the problem that the pump doesn't turn off spontaneously. So this is probably the best one is ever going to do with any kind of therapy. And it's interesting to know that that was obtained back in the mid-1980s. We like to use intravenous glucose as a secretagogue to measure insulin secretion. And the observation here worth noting is that these data are the recipients of a transplanted pancreas. This green area are normal controls. The transplanted pancreas briskly releases insulin just as the normal pancreas does in a normal person, and is the same die-away curve that you see. So this organ, transplanted in the pelvis, not really innervated neurally by the brain like a normal pancreas is performing wonderfully. It just seems to do the right things, both time-wise, phasic release, and it was a thing of beauty to watch when we first got the data back. Glucagon secretion is a very critical hormone to people being able to live. People don't think about the glucagon as much as they do insulin, but the way you test glucagon secretion is oftentimes with a hypoglycemic clamp. So you lower the glucose intentionally, and you see what kind of glucagon response the recipient will have. Here you have a comparison of glucagon responses during a hypoglycemic clamp, which just means we're infusing insulin and purposely lowering the glucose level in the subject, and then we track how quickly and to what magnitude glucagon is released. So here are the controls in red, pancreas transplant recipients in green, kidney transplant alone in purple, and these are people with type 1 diabetes mellitus, non-transplanted. A massive difference between a puny glucagon response in this case and a perfectly normal glucagon response after pancreas transplantation. And again, it's important to note this is a donated pancreas put in the pelvis, period. There's no neural connections. We have learned that the vagal connections are very important to regulation of the alpha cell, but it seems like it doesn't make much difference, or at least not as much as we had thought. Mike Maurer was mentioned earlier today. He's a nephrologist at the University of Minnesota. Mike is an incredibly patient person. With the recipients that David had transplanted in those days, Mike kept bringing back people to get kidney biopsies. So this was published in the New England Journal of Medicine in 1998. Here's a pre-transplant kidney biopsy. And for the nephrologists in the audience, you'll recognize this is a very abnormal looking biopsy. Still abnormal 5 years post-transplant, but 10 years post-transplant, all that glomerular matrix is cleaned up. So it's a great message to know that kidney disease and type 1 diabetes is reversible. It really incentivizes folks to normalize the glucose level as much as possible in type 1 diabetes independent of transplantation, because it tells you that kidney disease is reversible. Until this time, that was never noted. So this is an example of, if you look around after you do the transplants and start making measurements and clinical observations, you make other discoveries. This is from William Kennedy, also at the University of Minnesota. He was mentioned earlier today. This was an amazing observation. Here's a comparison after pancreas transplant compared to type 1 diabetes mellitus as controls. This is the inexorable decrease in neural function, motor, and sensory that you see with people with diabetes. But for those who are successfully transplanted in yellow, it arrests that continuous decline in neural function, both conduction. Questionable whether these are significant, but it is significant that you can reverse neural abnormalities if you control the glucose level after successful pancreas transplantation. Again, an encouragement to people who take care of people with diabetes without transplants. It's worth managing the glucose, getting the hemoglobin A1c as low as you safely can. And here I'll hypothetically mention that within this group is a subgroup of people with autonomic nervous system dysfunction. They're the people that you may be familiar with who get hypoglycemia, who have gastric motility problems, who cannot maintain the blood pressure. They act as though they're volume depleted. Those people are on track that says 50% of them will be dead in 5 years. So if you have a type 1 diabetic patient with autonomic nervous system dysfunction, they're on a path to sudden death. That's the group that I would say one should champion champion solitary single pancreas transplantation alone in, because they have a death sentence awaiting them. And when I see patients like that in clinical practice, I refer them immediately to the University of Minnesota to get a single pancreas by itself, not kidney, just pancreas, because they're having a difficult time surviving. How about the eyes? We mentioned the eyes earlier this morning. So these are 3-year post-transplant fundus findings and required laser therapy. The thing to focus on is the green color. This is simultaneous pancreas kidney, and this is kidney alone transplantation. So when you add a pancreas to a kidney transplant, you do much better in terms of maintenance of fundus. In terms of need for laser therapy, this is the combined organ. This is kidney alone. So you can see there's a difference when you control the glucose level in terms of eye findings. And these are fairly good numbers, 43 and 45. So to continue that theme, how about regression of atherosclerotic plaque? I would not have thought this would have been the findings, but it is these are the findings, that there's actual regression of plaque. So where you want to be after these kind of surgeries are where the green is, not where the blue is. So if after pancreas transplantation, but it's not lost, you get this actual improvement below the line here on the amount of plaque. This is in the coronary artery, and the control group is here. These are people who were transplanted, but they lost the pancreas. So again, complications are reversible, complications are preventable. How about islet transplantation? So here we got to think about both allo and auto islet transplants. So it'll be the same general theme of looking at success rates, beta cell function, and alpha cell function. This is a schema of one was shown earlier today. It just points out that both for allo and auto, you go through the same procedure. You have to isolate the islets, and the idea is to separate out exocrine fragments, try to purify the islets. In the case of allo-transplantation, not nearly so necessary with auto-transplantation. But in any event, you get the islets, and then you put a kind of a trocar transcutaneously in the liver, through which you can thread a cannula, and then there's an IV bag, and you just dribble in the islets. Catheter is retrograde in the hepatic portal vein, and then the blood flow just chases all the islets into the radicals of the liver. And you wind up with this, with islets in the sinusoids. And so we should look at some of those data. Now, when this initially happened, this is the so-called the Edmonton protocol. And what they did in Edmonton is they basically did the same kind of islet transplants that have been done before with allos, but they did two things majorly different. They allowed themselves to give not just 1, but 2, and sometimes 3 infusions over the course of a year. And they avoided the use of glucocorticoids as an immunosuppressant. Glucocorticoids are known to be toxic to beta cells, so that was a wise choice. And the game was, they were playing is how many times we'll get enough islets in until we finally get successful. We're not going to limit ourselves just to 1 islet transplant. After the first year, there was general euphoria because these were 7 out of 7 patients at this point, but had never been seen before. It was 7 sequential patients with normal glycemia a year after islet transplantation. These are type 1 diabetic patients. But with time, things deteriorated, so much so that 15% of the patients just totally failed. 77% were called partially successful because you could still measure C-peptide, and it had to be coming from the intrahepatic islets because their own, of course, pancreases were not secreting C-peptide. 8% had complete success. This was a little bit depressing because this was about 2001, as I believe it. 5 years later, things didn't look so good anymore. But, people rallied around and different centers got involved. Things did get better over time. So now the picture looks better. Currently, the last report I saw was the CIT-07 a couple of years ago. Insulin independence, it was now 58% out with time. C-peptide positivity, 92%. Again, this is solid proof that the islets are working, because remember, the native islets are not functional. In severe hypoglycemia, which is the primary indicator to have the islet transplant, was down to less than 10%. Presumably, all of these patients who got islet transplants were all experienced severe hypoglycemia. So this looks like that's been, quotes, cured, but there's one caveat. For example, here's the Bernard Herring published this in Diabetes Care. Here was baseline percent of patients getting severe hypoglycemia, 100%, but after the successful islet transplant, the allo-transplant, it's down to less than, probably negligible, less than 10%. Now, the caveat is this. The reason people with type 1 diabetes get hypoglycemia is they take insulin. It's not part of the disease. So if you're not injecting insulin, you don't get hypoglycemic. And the question remains, is the reason these people are not getting hypoglycemic because the islets are wonderful, or is the doctors are not giving them insulin anymore? So think about that, and I'll show you some data in a minute to help you think about it. Here it is here. So what we did, this is Barry Patey is an ex-fellow of mine. We decided to do the hypoglycemic clamp in islet transplant recipients to address the question whether alpha cell function was normalized. Was that the reason that people were no longer getting hypoglycemic? And the answer was a little unexpected, but it is anyway. So if there's a glucagon response, this is blue line, these are the normal controls. The red line are people with type 1 diabetes non-transplanted, total absence of glucagon secretion, and we knew that before. What we didn't expect is the transplant recipients also had a not impressive of any glucagon secretion during hypoglycemia, which caused us to scratch our head because we knew the alpha cells were in the islets that were transplanted, and we knew, I'm not going to show you the data, but we knew that because we could give those patients arginine, we could elicit glucagon secretion from the transplanted islets. So the islets were making glucagon, but they were not behaving normally during hypoglycemia. And I'll say a little bit more on that in just a little bit. We don't really know, we can't say much about chronic complications following successful allo-islet transplants. There have been a couple of reports saying some of the secondary complications are reversed or partially reversed, but it hasn't been studied completely enough to really tell you that's the gospel truth. I think that's the way it's going to go. It should. If you're normalizing the glucose levels, we know from pancreas transplant data, the complications should improve or reverse. But I think we'll need more studies to get there. So let's do auto-islet transplant. Now, Molina is going to follow me and discuss this issue in children and some adults, but I just wanted to be sure you're clear about who gets to get auto-islets, who gets to be pancreatectomized for chronic pancreatitis and undergo auto-islet transplants. And they had to be chronic pancreatitis refractory to medical treatment and endoscopic interventions. And I think it's a consensus now that the endoscopic interventions basically are not worth a great deal. People have been stented time after time after time after time. It just doesn't work. Medical treatment is not wonderful. So the patients of Minnesota who meet this criteria have got to first base. Narcotic dependence and significantly impaired quality of life is a must-be, but it's almost a no-brainer. Because if you've had chronic pancreatitis for over 2 years, most likely you're going to be narcotic dependent, and your quality of life can be really miserable in terms of getting to work, child care, one tragedy after another. You have to lack medical or psychosocial contraindications, no-brainer. And you have to be non-diabetic or C-peptide positive. So the trade-off here is some people who have chronic pancreatitis may be diagnosed as diabetics, mild if you do a glucose tolerance test. They have to understand that they may become blatantly diabetic if we don't get enough islets from their pancreas to put back in the liver. And the trade-off really is you have to be willing to accept the risk of diabetes for pain relief. this again is a no-brainer for these people. The people who come to Minnesota, and I'm speaking primarily of Minnesota, but I guess generalizable, are just miserable. You saw the picture of the young lady from Arizona. That's perfectly typical, you know. Nice-looking person, losing weight, getting depressed, on narcotics. It's just a miserable life. So what do we know about the success of this? You can't really deal with success rates with auto-islets like you can a whole pancreas, because you know what you're giving the patient when you give them a whole donor pancreas. When you do islet transplantation, all you can give them back is what you get. So as Bala pointed out, you don't always get a good yield. So the only way to really analyze this, and I really recommend this article by David Sutherland in JACS 2012. It's just a ton of really wonderful mineable data. So if you want to write anything down at all, write that reference. If you get from the auto-islet procedure less than 2,500 islet equivalents per kilogram, those are these data. If it's 2,500 to 5,000, you get these kind of responses. And if it's greater than 5,000, which is really basically about a third of a pancreas, you get really great responses. So what are these responses? These are C-peptide positivity, so it's measurable C-peptide levels, and a hemoglobin A1c level of less than 7%, not taking insulin. So really good control. Well, you can see the more islets you get, the better results that you get. So it's a quantifiable thing. It's not quite a dose-response curve, but the message is you want to do this operation for people when they have a lot of good islets. You do not want to wait 10 or 15 years when they destroyed half their islets and then think about doing a pancreatectomy and then think about doing auto-islet transplants. I think this is a great argument for doing preemptive total pancreatectomy in people with chronic pancreatitis and big-time pain. I don't see any point in doing partial snipping away at the pancreas, hoping to get an area that's involved when historically, you know, there's going to be another area involved pretty soon. And I'd like to have that debate with John if he's here. He's back to clinic, okay. But I think it's a great discussion to have because, again, as Reiner pointed out, I think, maybe subliminally, there is resistance to exception to this procedure in the medical community. And I don't get it. I don't get why it's not in Williams' textbooks of endocrinology. I don't know why up until a few years ago it wasn't even in textbooks of transplantation. There's a strange feeling that doctors get about taking out somebody's pancreas. Not surgeons, obviously, but other doctors. And we just got to get over this because there's a lot of people suffering with chronic pancreatitis. They don't need to. I think practically speaking, if you're going to consider this procedure, do it as soon as it's evident this is going to be chronic, unrelenting pancreatitis. That's very painful. Why wait? Insulin secretion data from the auto-islet transplant looks something like this. These are simply measurements of beta cell function. I won't go into what all the alphabet soup makes, but this is a normal response, control response. This is a control response of a different way of measuring insulin. This is what you get from recipients of auto-islets, not quite as tall as the blue bar, and this is what you get from auto-islet recipients, not as tall as the blue bar. But if you correct those values for the number of islets you've transplanted, because you know that, they've been counted before you put them in the liver, and just divide the number you get by that, then you get the green bars. Key thing is this is this response per islet number, where the control response is assumed to be 1 million. A million islets is what we assume is in the pancreas. It's very encouraging. This is actually greater, although not statistically greater than normal, and this is comparably normal. So I think this presents the case. If you know the number of islets, and you measure C-peptide or insulin, and then divide that response by the number of islets, you should expect a normal response, in quotes. And if you turn that argument around, you do that response, you have the individual data for an individual, you can extrapolate and make a guesstimate of how many islets are actually alive in the transplanted liver. So the beta cell summary So both baseline and glucose-potentiated acute insulin responses and C-peptide responses are normally timed in these recipients. So think about that for a minute. Now you got the islet in the liver, and it's every bit as responsive in a time fashion as a normal islet in a normal pancreas. It's a pretty good accomplishment. These responses correlate very highly with the number of islets transplanted, and these are very high correlation coefficients for any kind of clinical investigation. So just think about flipping the axis and say, well, we got the response now. We ought to be able to reason backwards and figure out how many viable islets are actually in the liver. And as I showed you, when you correct that number of islets you've transplanted correct the responses by the number of islets transplanted, you find out that the responses are normal, regardless of the duration of the graft, which makes another statement. Some of these people have been transplanted for 2 years, some for as long as 15 years, and yet they're all on the same correlation coefficient slope. That's a statement that suggests a transplanted islet in the liver lives a long time. There's no slow death. They should be there long after you've placed them there. Let's turn back to the alpha cell. Turn back to hypoglycemic clamps. Because remember, I told you that the allo-islet recipients had failed glucagon secretion during this particular test. And the same is true here in the auto-islets. So this is glucagon secretion. Controls in blue, the auto-islet recipients in red. There's no response of glucagon from these intrahepatic islets, consistent with the allo-islets. But it just so happened that when surgeons do this procedure, if they have too many islets and they cannot get them all into the liver, the custom is to put them into the peritoneal cavity. That was done with 5 of these people. So now we have TPIT in hepatic plus non-hepatic at H sites, 5 patients. And this is the response that we saw. They had normal glucagon secretion to hypoglycemia. This has been reproduced now 3 or 4 times in different studies. And it makes me think, and I think other people begin thinking, is the liver the best place to be putting islets for islet transplantation? What about other sites? Well, this slide by the green bar says, well, one other site, the peritoneal cavity, can receive the islets will function, and they will have normal alpha cell function to hypoglycemia. There are many other sites one consider than the peritoneal cavity, but this is just an example of saying we should look at this much more closely. Is the liver really the smartest place to be putting islets? Even though they work for beta cells, they're obviously not working cleanly for alpha cells. I say that with confidence because what we do our control study is to give the patients, the recipients, intravenous arginine, because that's a good agonist for glucagon secretion also. In all cases, the people who don't respond, who've gotten their islets in the liver to hypoglycemia, they do respond to intravenous arginine normally. So we know the alpha cells are alive, they're functional in the liver, they just don't perceive hypoglycemia. Symptom scores are very important when you think about hypoglycemia. That's the symptoms the patients have as we purposely make them hypoglycemic. Control subjects do everything you expect them to. They get warm, they start sweating, they don't see as well, they don't think as well. We take them down to a glucose level of about 50. So that's what we call the symptom score. The symptom score to the folks who got intrahepatic islets shown in red here, the symptom score were the 5 patients that got them in the peritoneal cavity, look like this. So they have symptoms. Well, why should that be? It's because if you are recurrently hypoglycemic, you get desensitized to hypoglycemia. The people who got the islets put in their peritoneal cavity weren't getting hypoglycemic, so they did have a response now during the hypoglycemic clamp. So it's a second reason to really rethink about where we're putting islets, because if your symptom response is so bad, for here, the red ones, that's not safe. Because what that means is you can become hypoglycemic and drive a car off the road and never know what happened. So we don't want to be making people void of symptoms to hypoglycemia. It's even important in the auto-islet transplants because some of those people will start taking insulin again. As I mentioned earlier, the only way you can get hypoglycemic is by taking insulin. So if your patients are going to be at risk for taking insulin again, allo-islet or auto-islet, then is liver the best place to transplant because they will not have a protective glucagon response and they're likely not to have a good symptom response. Okay, just to finish up, the people with auto-islet transplants who tend to complain about spontaneous hypoglycemia, and many of them do when you question them closely, will tell you that when they get symptomatic hypoglycemia after auto-islet transplants, it's after exercise or a high carbohydrate meal. We've done studies of exercise tolerance on a bicycle, and on that study, the patients showed that they actually were deconditioned, surprisingly so for their age and their weight, but some of them tended to get hypoglycemic without a glucagon response. That was even more evident with this particular study. Here we're giving a mixed meal loaded with radioisotopes, and I'm not going to show you the isotope data, but I want to show you some of the hormonal data. Look what's happening to the glucose level in the recipients compared to the normal controls. They're getting twice as hyperglycemic with a fixed glucose load, and then they dip down below normal. So they get this huge increase and then this huge fall. If you look at their insulin data, well, this is just another illustration of that. At the end of the curve at the 5 hours, this is where the normals were. The people who were auto-islet recipients were falling down appreciably down to minus 60 milligrams per deciliter. So that was a serious fall. Here's the insulin responses in the same people. The normal controls here are shown in the open circles. That's what it should look like for the insulin response. The recipients had a lesser response. Remember, they don't have as many islets as the normal control, so you wouldn't expect them to be as great. But if you corrected that response for the number of islets they got, you got a huge response, which would be more appropriate for the kind of hyperglycemia the patients are getting. I mean, those islets are responding to the glucose level. Same for C-peptide. So you correct the C-peptide response for the number of islets received, it's greater than it should be for the given glucose level. What was glucagon doing all this time? It was doing nothing. So once again, these people had their islets in the liver. They're getting hyperglycemic with reflexive hypoglycemic at the 5th hour. Insulin's going way up and C-peptide is going way up. Glucagon's doing nothing. This is what patients complain about. I get hypoglycemic after a high carbohydrate meal. I get hypoglycemic after severe, high degrees of exercise. So I think this explains why this gets so low. So in summary for that, this large increase and decrease in postprandial glucose occurs in this sort of glucose tolerance test. There are absent glucagon responses at that time. And these are just the radioisotopic data you can't even see and you probably don't want to hear about. But we measured insulin resistance, endogenous glucose production, and glucose sensitivity. There are no differences there. So the only differences we could find was yes, they get hypoglycemic. No, they do not secrete glucagon. So here's the alpha cell summary. I don't have to read it for you. I just said it again. Remember, these are all controlled by arginine, so we know arginine is our gold standard. If we can get glucagon out of an alpha cell with arginine, why can't we with hypoglycemia? And just to reiterate the point I've been making ad nauseum here, to the surgeons is think about non-hepatic sites. There's no reason not to try it. It works. I know it works because if it didn't work, patients wouldn't be normal glycemic, and they secrete insulin. So the peritoneum, which has been avoided for a long time because people thought vasculature wouldn't be enough to support islets, simply not true. It really will. So I think this is the last slide. So pancreas transplantation, kidney transplantation, if you can have transplanted a kidney for a diabetic, give them a new pancreas too. There should be no reason not to do that, especially if you have an autonomic nervous system insufficiency. Like I said, figure to remember, 50% of those people will be dead once they're diagnosed, within 5 years of the diagnosis. Allo-islet hypoglycemia is a indication, but just remember the reason they get hypoglycemic is because they're taking insulin. Just because there's no more hypoglycemia after allo-islet transplantation doesn't mean the islet has done the trick. What's done the trick is people are not giving them insulin anymore. And of course, allo-islet transplantation, I think, is absolutely indicated in chronic unrelentingly painful pancreatitis after 2 years. I mean, might as well get with it while the pancreas is healthy, and you can get it out with ease and get a much higher islet yield. And David Sutherland was mentioned. I just talked to him on the telephone. So David's pretty perky today, so that's good to hear. And there are a lot of people who helped out. Molina has been a huge help. And some of the earlier work I did in conjunction with James Shapiro, Eddie Ryan, and Bray Patey. So that's it from Seattle.
So Dr. Robertson will have to leave early. I think we'll make an exception, and if there are any questions, because I mean this is really fascinating material, the differences between pancreas allo, islet allo, islet auto transplants. Paul, there are actually a good number of medical students in the audience. Can you explain to them very briefly what a hypoglycemic clamp is? Because I'm sure, I mean, they understand what arginine stimulation, glucagon stimulation is, but what is the hypoglycemic clamp? Robert, can we have sound?
Well, I am an endocrinologist. I needed a surgeon to point that out to me. So a clamp study is when you try to get a glucose level at a certain level, and you do this by infusing glucose first, and then maybe 5 or 10 minutes later, after you've elevated the glucose level, you infuse insulin to try to bring it back to a given level. And you can do this by measuring glucose levels every 5 minutes. That's a simple thing to do. There are hyperglycemic clamps. So when you want to let the glucose level rise up to, say, a level of 300, then you start infusing the insulin to get it to a rest there. So you want to study what the patient's behavior is like at a hyperglycemic level, and you clamp it, so to speak, by simultaneously infusing glucose and insulin. Hypoglycemic clamp is the same thing, but it's just the opposite. You infuse insulin first, you get the glucose going down, and then you try to break it by infusing glucose. And we call that a stepped clamp. Usually we do it at 90, then 80, then 70, then 60, then 50, we stop there. And that's is a great way to measure glucagon responses, because it gives you responsivity, it gives you a magnitude, sensitivity to the hypoglycemia, so all kind of neat parameters that you can measure.
One question that came up, obviously, it appears that the liver is toxic to alpha cells. Because the beta cells, I mean, you do see a response. Alpha cells, you don't see the response. You know, I mean, I just wonder, I mean, does that make any sense? Why?
So let me save you from yourself, Ryder.
Huh?
Let me save you from yourself. The alpha cells in the liver are perfectly normal. They do release glucagon to arginine. Mm-hmm. So they're not a victim of toxicity. But what you're asking is a great question. So that's why we did the experiments, and we could do these in rats. And that was to go through this hypoglycemic clamp business. But do it in rats, it's a complicated model, but do it in rats and see the lack of glucagon response until we fasted them for 48 to 72 hours and depleted the liver of glycogen. Mm-hmm. When the liver was depleted of glycogen, the islets and the rat's liver released glucagon perfectly. Mm-hmm. So I think the best guess that I have is that if you have a lot of glycogen in your liver and you put islets in the liver has all that glycogen, they're being fooled because the glycogen keeps breaking down all the time and bathes the intrahepatic alpha cells with glucose. So the alpha cells in the liver are perfectly happy. They don't think they have to go to work because there's lots of glucose around telling them not to secrete glucagon. But if you deplete the liver of glycogen, those intrahepatic islets are perfectly normal. So there's no toxicity. Okay. It's just a matter of understanding that glycogen is being made and bathing intrahepatic islets all the time, especially if you get slightly hypoglycemic, because that turns on glycogenolysis. So I think it's a very functional, physiological, wonderful thing, just not very useful clinically.
Comment, Bernard, from the allo perspective?
Among the many things that you outlined, the susceptibility of auto-islet recipients to hypoglycemia compared with allo-islet recipients. So I think it is the same implantation site, but there must be important differences in GI reconstruction that make patients very susceptible to hypoglycemia after total pancreatectomy. Because in allo-islet recipients, at least clinically, there is no hypoglycemia-related problem as opposed to auto-islet recipients. I think this works, yeah.
Well, you know, Bernard is a very logical guy. He's an endocrinologist, too. The thing is that one of the major differences between allos and autos is the autos get a Roux-en-Y. And that just completely disrupts the architecture. I mean, I don't know what's happening to the vagal nerves after surgeons get through with their Roux-en-Y, but I'm sure that has something to do with the differences between the two patient groups. And the other major difference is, and I'll just hang on to this, is that the successful allos don't go back on insulin. It would be an interesting study to repeat that again. I mean, we did this with earlier with Bray Patey's study showing the hypoglycemic clamp in allo recipients, some of the first ones that James did. They had no glucagon response to speak of. Now, there have been a couple of publications suggesting that there is a glucagon response, but that's not the same brisk glucagon response that you expect to see in normal subjects. So Mike Rickles and I have this argument, but it's not an argument, it's a friendly discussion. You know, he'll say, oh, no, there are alpha cells that are releasing glucagon. Well, yes, Michael, they are. But when Michael does his experiment, he does it in such a way that there's an antecedent epinephrine response before he sees the glucagon response. Epinephrine is a secretagogue for glucagon. So, I mean, I hate to get tedious about this, but if you reason your way through this, the alpha cell doesn't get away scot-free. It'll be compromised. If enough of the allo recipients start taking heavy doses of insulin, I think you're going to encounter people who don't have a glucagon response and who have decreased symptom awareness. But fortunately, the allos that are, you know, they're successful, so they don't have to undergo that test.
So, Paul, we have a few patients in whom we do not use a Roux-en-Y. We just bring the jejunum all the way up, and then, I mean, just continues in continuity. So it would be interesting to see in those patients if there is a difference to the one that have a Roux-en-Y. Because, I mean, we all have observed, obviously, patients after islet auto-transplants to have hypoglycemic episodes. But I think it would be interesting because we have done it in both ways. We have taken only one. We have done it with a Roux-en-Y and without the Roux-en-Y, and we have a few patients that actually have two Roux-en-Ys, where we use one Roux-en-Y on the duodenal gastric side and one on the liver side. So maybe what we'll do is we'll send you some samples of these patients, and we'll have Dr. Banerjee work on it, because, I mean, this is fascinating.
Well, I think what you should do, because, you know, I'm not going to keep doing this work forever, right? I'm retired. Right. So we need to train more endocrinologists to get involved here in Brooklyn, and you should do those studies here.
Yeah. Well, I'm just asking out of curiosity, how much work has been done in bariatric surgery in regards to glucagon responses? Because, I mean, there you're obviously, I mean, dealing with very long Roux-en-Ys, and it would be interesting, and I'm not sure if there's even any literature that exists in that regard.
Well, there's a burgeoning literature of hypoglycemia in bariatric surgery patients. It's just becoming recognized now. And I think it's going to be a good counterpart to what we're seeing with the auto-islet recipients. Because during their surgery, again, Roux-en-Y is often part of the thing. Different kinds of bariatric surgery, I guess. I'm not sure which ones are popular now. But if you start doing major surgery in that arena, you'll be doing things that interrupt vagal blood flow, vagal neural flow.
Mm-hmm. Any other questions for Dr. Robertson? If not, thank you very much, Paul, for... Our next speaker is another, actually, is a true Minnesota product, Dr. Molina. She is from Minnesota. The only time in her education that she spent outside, if I see that correct here, was when you got your BA at Cornell. Is that correct? Dr. Pauline is associate professor, and she is the director of the Islet Auto-Transplant program. She is a member of the Department of Pediatrics. She is currently the PI on several NIH grants, active grants. She has over 100 publications, and she has extensively published about islet auto-transplants in children. And as you know, there are very few institutions that have done pediatric auto-islet transplants, but Minnesota is really the mammoth amongst these institutions, having done almost 150 or so. And Dr. Pauline will tell us, where things are with regard to pediatric transplantation.
Thank you. Well, I was charged with this title of TPIT in children and adults, so I'm going to give you a lot of pediatric data, but I'll actually present that in the context of the entire program. So I'll talk a little bit first about the clinical rationale for TPIT, but I think you've heard a great deal about that from the speakers this morning, why we do this procedure. And I'm really going to focus then on the outcomes after this procedure using population-level data. So I'm going to talk a lot about health-related quality of life, pain outcomes, and narcotic use, because that's really the main reason why we do this procedure. And then I'll go into a little bit more globally the diabetes risk after TPIT. And I'll embed in here comparing children versus adults. Very similar in many ways, but there's some unique considerations and unique outcomes in children that I think are very interesting to discuss. So you've seen this figure before. You know that chronic pancreatitis is a very painful disease, and I put this up here first and foremost to just reiterate the point that the reason that we're doing TPIT in these adults and children is not based on diabetes risk. It is the TPIT is done to treat painful chronic pancreatitis. And what does our population look like? Why do they have pancreatitis in the first place? Well, certainly within the children, we see a lot of hereditary disease. This is mainly disease affecting the genes of the trypsin pathway. So PRSS1 is an autosomal dominant mutation in trypsinogen that leads to autoactivation of trypsinogen to trypsin within the pancreas. And SPINK1 is a trypsin inhibitor, so sort of the other side of that pathway. We also see patients who have 1 or 2 CFTR mutations, not classic lung disease cystic fibrosis, but an exocrine-sufficient form of cystic fibrosis at times where they get recurrent acute pancreatitis. It's about 80% of our kids who fit into that population, about actually 15 to 20% of our adults. We also see a lot of idiopathic disease, particularly in adults. We see patients who have pancreas divisum. Now, that oftentimes is complex with genetic mutations. We, once in a while, might see a toxic etiology or an autoimmune etiology. What I didn't put up on this list, which we do see, is we do see a few patients who have alcoholic pancreatitis. I think you heard this morning that actually the majority, a little more than half of patients with chronic pancreatitis do not have alcoholic disease. Those who do have alcoholic disease are oftentimes not great candidates for TPIT, particularly if they have ongoing chemical dependency issues. So in very selected cases, we have alcoholic pancreatitis, but really the vast majority are idiopathic genetic disease patients. So when disease is refractory to medical and endoscopic interventions, that's when we maybe step up to a TPIT procedure. Again, I think of this as the primary goal is a pancreatectomy. Our first goal is to relieve pain, improve quality of life, because this is a disease where people who come to surgery are really suffering. And then I think of the islet auto transplant as a secondary goal of the procedure. So we could do that total pancreatectomy alone, remove the pancreas without the islets and treat the pain component, but the diabetes can be difficult to manage and can, thereby impair quality of life. So our goal with the islet auto-transplant is to, as much as we possibly can with the islets that are there, prevent or minimize that post-surgical diabetes. It's a very simplistic diagram of the procedure, so you heard much more about the surgical procedure this morning, but just as a reminder, we are infusing most of the time those islets into the portal vein in the liver. So you heard from Dr. Robertson just before me about how we select patients for surgery. So just a little bit about how our program is based, and I think how many programs are based. We have a multidisciplinary team. So this isn't a surgical program, it's a combined surgical medical program. We get referrals at the University of Minnesota that come from throughout the country. We have a team that consists of multiple surgeons, endocrinologists, GI physicians who specialize in pancreas, nurse coordinators and nurse practitioners, pain doctors, psychologists. Generally, any given week, there's about 10 to 15 of us who meet from 5 to 6:15 p.m. on Wednesdays, and we review every single case. So before the patient gets to us for a TPIT eval, we sort of do a pre-review. What do they need other than kind of our standard eval process while they're here? And then we have a very comprehensive review after an evaluation process. And when we have that comprehensive review and we're trying to think about should we recommend surgery for this patient or not, this is the list that we're going through. And so first and foremost, we want to make sure that that patient has abdominal pain because they have chronic or recurrent acute pancreatitis. Much of the time this is straightforward. Particularly in children, it's usually straightforward. Once in a while, it's not. And so if we have an adult who has chronic pancreatitis without a real clear history of acute pancreatitis, and they don't have calcifications on their imaging, we are relying on more than one diagnostic test, an MRI, an EUS, pancreatic function test, endoscopic pancreatic function test, to really tell us that truly is chronic pancreatitis causing their pain, because we really want to avoid doing this major surgery if that is not the source of the pain. We want to do this with people who are actually significantly impaired. So usually the people who get to us to consider for surgery do not have mild chronic pancreatitis. They usually are pretty disabled by the time someone is coming in for this major surgical evaluation. But once in a while not. Sometimes someone comes to us early in the course of recurrent acute or chronic pancreatitis and they're functioning pretty well. And a lot of times this is individualized. So for example, a few weeks ago, I met so I see the adult patients in consult too. I met individual, an adult male who was a firefighter. And so he was working, he had chronic pancreatitis, very clearly had chronic pancreatitis, but he was working full time, he wasn't on opioids, he was managing his pain, and he wanted to come and learn more about surgery, but we ultimately decided this was probably not yet something to go to because the risk of him having to be out of work and have a worsened quality of life because of the surgery we thought was high. So it's not everyone that comes through with chronic pancreatitis who is eligible or a great candidate for this surgery. The next thing on the list is lack of medical and psychosocial contraindications, and I want to highlight this because we see a lot of patients who have significant psychosocial issues around their chronic pancreatitis. So it's really common for these patients to get anxiety, PTSD, depression, and one of the things that we've really tried to ramp up in our program over the past decade is supporting those patients and treating those issues as much as possible before they go through this major surgery, major recovery process. So we have a process that our pain doctors a while back termed prehab. And so we actually have a focus on prehabilitating people to be ready to go through surgery. And a lot of the times that includes physical therapy, it includes sending them, making sure they're established with a psychologist that they can see on a regular basis at home. We see many patients where we defer surgery for 6 months. So we had a little girl who had surgery in December who's doing great. She had hereditary pancreatitis. She came to us in June of last year, and she came to us in a wheelchair, not walking and not going to school, taking narcotics every day because she was in so much pain. Her mom said she couldn't possibly do those things. And so our pain team worked with her, and a caveat to getting her to surgery was that she had to be going to school. She had to be not using a wheelchair. And by the time she came back for surgery in December, they stopped and did some sightseeing on their way up, and she walked for 8 hours a day. So she still had chronic pain, but she was functional. This is the state we want to get our patients into before they go to surgery. And so then the other things are, ideally, we have a non-diabetic patient, and everyone, even if they're non-diabetic beforehand, has a risk of diabetes, so they have to be willing to manage diabetes. So with that, I'll talk about a couple clinical examples, and then I'll go into the outcomes. And I'm going to give you one clinical example of a child and then one of an adult. So this here is a 4-year-old, not 4 years old anymore, but 4-year-old gal at the time who had recurrent acute pancreatitis that probably started around age 18 months, but many times in these children, they unfortunately don't get diagnosed with the right condition right away. So oftentimes providers, if they haven't seen pancreatitis in a child, aren't thinking pancreatitis. So by the time she was 2, she was properly diagnosed with acute pancreatitis. She was a little bit unusual. She was actually idiopathic, which is, usually we see hereditary disease at this age, and she had kind of a chronically enlarged pancreas. There was actually some thought maybe she was autoimmune pancreatitis, so people had tried treating her with high-dose prednisone, with azathioprine, trying to resolve the pancreatitis. She had been to 3 or 4 different specialists around the country before she came to us. She was in the hospital 12 times. She couldn't go more than 2 weeks without having a bout of acute pancreatitis. She was constantly in acute pancreatitis and pain. So that was the context for bringing her to a TPIT procedure back in 2012 when she was 4. She's not had any hospitalizations since she got out from her surgery admission. She has no pain. She's not been any narcotics since 2012. What I think is actually kind of remarkable about her is they came in one time, maybe it was 3 years or so after surgery, and I always ask if they're having any pain, any pain like pancreatitis, and her mom said, you know, actually she doesn't have any pain, but she doesn't even really remember having pancreatitis or surgery. She asked us where this scar on her abdomen came from. And so just a remarkable tribute, I think, to the resilience of children. They can really just fully recover these things. She has had periods off insulin, but she's mostly been on a low dose of basal insulin. Her A1Cs usually sit in about the 6% range. She actually just had one at 7 years, and I think it was up to 7%, so we're increasing her dose a little bit. But she is C-peptide positive, clearly has great function of her islets, and the diabetes management has just not been an issue at all, and she's been happy and healthy. So in terms of our adult spectrum, we oftentimes see kind of middle-aged, young to middle-aged adults. We see a few more women than men in our population. So this is a 32-year-old woman who came to us with chronic pancreatitis that was idiopathic, so very typical pancreatitis of 7 years. Just very remarkable number of ERCP procedures. So she was she was seen by a physician in a program that was very endoscopic heavy. So by the time she saw us, she had had 70 ERCPs. About half of those were to place stents and half of them were to remove stents. And she was on oral morphine, and she had left her job, and she was living with her parents. So that was the context for bringing her to TPIT. She's someone who we ideally would want to see earlier in this process, not dealing with this for 7 years and 70 ERCPs. She had her surgery in 2011, and she had one admission subsequently in 2016 for lysis of adhesions because she was having some pain and possibly small bowel obstruction issues. And that's fairly common in our adult population to have a little bit of kind of chronic issues here and there. But at 8 years post-op, she's not using any narcotics. She is mostly pain-free, or at least she has manageable pain when it occurs. She was insulin independent for 7 years, and then when her A1C went up to 6.8%, we started her on a little bit of basal insulin. She went back to working full-time. She moved out from her parents' house. She got married. She bought a house. So she did all these functional things that she could not do when she was disabled with chronic pancreatitis. So the children versus adults more or less have the same surgical procedure, the same type of evaluation process, with the exception of things like child of life and more kind of pediatric focus in the children, but there are some unique considerations. And so these groups of patients, I would argue, differ somewhat in the etiology of their disease. We do see genetic disease in adults, but it is by far the most common thing we see in our children. In our children, we're thinking about things like school attendance. We're thinking about growth and pubertal development, so there's some unique considerations there. You heard earlier about some of the technical challenges with small children when it comes to isolation. There are also technical challenges to doing this surgery on a smaller patient, so that's always a consideration, particularly when we're talking about 3- and 4-year-olds. We usually, if possible, are actually trying to delay that surgery for just a little bit of time to get them a little bit bigger. In any population, adult or pediatric, we need those patients to have a social support system, but more so, mostly in children, we really deal with the parent dynamics and the family dynamics there. And adults are just in general more complicated. Some of our teenagers are complicated as well, but I'd say in general the adults just have more medical comorbidities, more psychological comorbidities, so they're a little bit more of a mixed group. So we have had an active TPIT program since 1977 when Dr. Sutherland did the first case. It's actually the first case of TPIT was actually performed to establish that the islet transplant procedure could work for allo-transplants. So it was historically done actually to provide proof of concept for allo-transplant, and then it just evolved over time into a procedure in and of itself to treat these patients with chronic pancreatitis. But I think what you can see here, and this really reflects the growth across the country here, is that the volume was very, very small. And this is somewhere around 2005, 2006, that the volume of patients in the US and at our center who are coming for TPIT has really dramatically increased. And I think that's really important because that has set up an opportunity for us to actually learn more about this population. And so we have a research program at the University of Minnesota that has evolved over time. And 2005 and before that, there was some very interesting research by Dr. Robertson, Dr. Sutherland, in terms of the metabolic function of the islets, some retrospective case series, some really interesting case reports, including the first pediatric TPIT. But we really, when we got to having this big volume of patients, that set the stage for some other opportunities in research. And David Sutherland was able to establish in the late 2006 our first observational study in TPIT. So now in the past 12 years or so, everyone who comes through for surgery is asked to enroll in a prospective follow-up study so that we can collect outcomes data from them. And I won't talk about them much, but have also added some additional clinical trials along the way. So most of the outcomes data I'll show you today evolves from this research program. So what about the pain outcomes and quality of life after TPIT? Because this obviously is the most important thing for the patient who is coming through to see us. Well, we also look at health-related quality of life scores using an SF-36. So you heard a little bit about that this morning, but it's a standardized health-related quality of life instrument. And if you look at the whole population, the average in the whole population, we see that standard deviation scores improve by about 1 standard deviation score on average on this SF-36. And there are a number of different subcategories that are measured by this SF-36, but the greatest improvements, probably quite logically, are seen around bodily pain scores and physical function scores. So that clearly is what TPIT is really treating. But we also see improvements in vitality, emotional health, and other areas. We also ask people as part of our observational studies just to provide a perceived health status. So we basically ask them, do you perceive your pain as better now than it was before surgery? And so using that questionnaire, about 85% of patients at pretty much any time point will self-report that their pain is much improved or resolved. The challenge that we have, and I'll kind of come back to this a little bit in this presentation, is that in the entire population, about 15% of patients will say that they have a similar pain burden as before surgery. So one of our big goals has really been to reduce this proportion of patients who have the same pain burden. So what about looking at that quality of life in children versus adults? Are children different there? And yes, they are a little bit different. So this is data that actually is a little bit more than a year old now, pulled from our database of nearly 1,500 responses in nearly 500 patients who have had TPIT, including just over 100 children. And so the two broad indices that you can pull out of the SF-36 are the mental component summary score and the physical component summary score. And these are actually normalized to a population mean. So if you look at these graphs at the number 50 up here, that's actually what a normal population would be expected to score at. And one of the things you can see, whether we're talking about children who are in the pinkish colored circles there, or the adults who are in the gray squares, is that both of those populations are quite impaired at baseline, as you would expect. So each 10 points here is about 1 standard deviation. So they're sitting about 1.5 to 2 standard deviations below average for their health-related quality of life scores, because chronic pancreatitis is such a disabling disease. And then what's quite remarkable is that both groups, adults and children, have a pretty robust improvement in health-related quality of life scores after surgery. What you can notice there is that the children basically normalize on average, and so they have a really robust improvement in health-related quality of life after surgery, and it is sustained, and it is more than the adults statistically. But I don't mean that to draw away from the benefit in adults, because even the adults are improving by one standard deviation score on average. I think this just reflects that the adults are a much more mixed group. They carry with them a lot more baggage, and they have more other chronic medical comorbidities that may be contributing to health-related quality of life. But both groups do well, but children do dramatically well. So we do look also at patients who have recurrent acute pancreatitis but don't have evident chronic pancreatitis on their imaging as candidates for this surgery. There's also very limited medical treatment available for patients who have recurrent acute pancreatitis. And so we see, that's our minority, I would say, but we do see a few of those each year where it's just recurrent acute pancreatitis. What happens is actually you resect this pancreas at surgery, you send it for histopathology, and most of them have chronic pancreatitis on the histopathology. They just didn't have bad enough chronic pancreatitis yet to see it on their MRCP. And what we see in that population is very similar improvements. These are mainly adult patients. They also have an improvement in their health-related quality of life scores on the SF-36. They also very successfully wean off opioid therapy, at least as much as our chronic pancreatitis patients do after surgery. And I'll get back to this opioid use with our entire population, but that's always been a challenge for us to get someone who's chronically on narcotics all the way off narcotics can be a really difficult challenge in this population. So I think that's coming up next. So if we look at this population before they have TPIAT, and we look at children and adults, the vast majority, especially the vast majority of adults, are chronic daily opioid users. Now that is fortunately less frequent in our children, especially now. Pediatricians try to spare opioid therapy whenever possible in children. 100% of these patients use opioids intermittently. So when they get an acute flare of their disease, they're on opioids, but many of them are on everyday daily opioid therapy. Now if you look at opioid use, and this is actually really any opioid use after TPIAT, it's dramatically decreased at 1 year. And particularly for children, by 1 year after surgery, about 25% of the children are still using some opioids. That's usually teenagers who have a chronic opioid use history. But about 50% of adults are. And so getting adults completely off opioids has been one of our big challenges. When we look at our pediatric population, we see that withdrawal from opioids does seem to be sustained. So this is a little bit of an older publication, but I think is very consistent with what we still see. And that is that there still are these 10 to 15% of patients who may use some opioids in the pediatric population, but that's fairly sustained, even over a 10-year interval. We see that 90% of these children, if you would just ask them about pain scores, they have improvement in pain scores. And as I showed you previously, they have improvement in health-related quality of life. We like to look at child-specific functional parameters in our children. So we look at in our children on some of the questionnaires that are administered to the parents as part of the observational study. What about school attendance? What about normal childhood function? So this is what these graphs are showing you here. This one is school attendance, and this is limitation just in all childhood activities. And you can see at baseline, the majority of children, they may be attending school, but they're missing a lot of days, so it's interfering with their school attendance before surgery. Most children are limited more than half of the days in a month because of their pancreatitis, and that dramatically improves after surgery. These patients are much more able to attend school regularly, more able to engage in things like sports and clubs and time with friends and family trips and all of this. But when do we fail to improve pain in chronic pancreatitis or recurrent acute pancreatitis? So we looked at this. We looked at this in the entire population because even though we have almost 150 pediatric patients, it's still a relatively small population compared to our total volume of 750. And so this is work that came from Dr. Chinnakotla, who's our pediatric surgeon. And the risk factors in our population to date for failure to either get off narcotics or improve pancreatitis type pain. The biggest one, I think this is consistent with other surgeries in the chronic pancreatitis world, patients who used opioids for a long time before their procedure, 5 years or longer, were more likely to have both chronic pain issues and stay on opioids after the procedure. think that represents some of the central sensitization and the opioid-induced hyperalgesia problems that happen in this population with long-term narcotic use. And to Dr. Robertson's earlier point about early intervention, I think this, along with the diabetes risk, is another rationale for considering earlier intervention in someone who is likely to go on to need TPIT surgery. The other ones, are a little bit mixed. More stenting, pancreas divisum, prior Whipple. I think these might have been markers of things in our historic population, and particularly, I think some patients who have divisum may get misdiagnosed as pancreatitis when they have chronic abdominal pain, and that's all that's found, and get exposed to repeated stenting procedures. So I do think that historically we've seen a proportion of the population who maybe had iatrogenic pancreatitis from ERCP interventions, and perhaps their abdominal pain was due to a different etiology. So we have recently looked with Dr. Chinnakotla heading this project at 10-year outcomes after TPIT. So the question was, is this sustained, this benefit that we see in TPIT? So these were patients who, 215 patients who had TPIT up until 2008. So they're still kind of a historical population. I have to put this in the caveat that really we have a very standardized medical management and follow-up protocol now after TPIT, and that was really implemented around late 2006 to about 2019. We implemented all these protocols. So these are patients who were actually not even managed on our current follow-up protocols. 215 patients had surgery during that era, but actually 140 of those were available for follow-up. The Kaplan-Meier survival at 10 years was actually 72%. I think that is reflecting both the higher mortality in patients with chronic pancreatitis and also that these patients, particularly historically, did not get referred for surgery until they were very late in their disease and had a lot of complications. But I do think what was interesting out of this mortality data is that the strongest risk factor for mortality was actually obesity. So patients who had a BMI greater than or equal to 30 had a 9-fold increased risk of mortality. So what about pain improvement, and is that sustained long term? So in that survey that we implemented and before that clinical follow-up data in terms of pain improvement, is pain better than before surgery? Well, we were able to actually get that data for the majority of patients at 10 years. The gray is missing. So this includes missing data in this bar graph for about 15% or so of patients at 10 years. But even accounting for that missing data and assuming maybe they're in the worst category, 80% of these patients at 10 years still identified pain as better than before surgery. And of those we were able to follow up, it was about 10% at that point who said that their pain was the same or rarely worse than before surgery. So the pancreatitis pain in particular is dramatically improved. So you ask patients, do they have the same type of pain they had with pancreatitis? This goes way down to 10 to 20% of the population. What we do see, and I think this is consistent with other groups, is there is some chronic abdominal pain in that population. I think this is a mix of neuropathic type pain, a mix of GI type discomfort. If you underdose on your enzymes or forget a dose of enzyme, you get some cramping discomfort. And other things that we see, like chronic constipation. We see some very bad dysmotility issues in this population. But importantly, I'll be talking to patients sometimes and we'll be going through their current abdominal pain history and some of these issues like chronic constipation, cramping pain, all that kind of new type of pain. And then I'll just say, well, do you think it was worth it to have this surgery? And then the vast majority of the time they say, oh yeah, well, this is way better than the pancreatitis I dealt with before surgery. But still, I think opportunities to really improve some of the outcomes. And then the other challenge is if you look at narcotic use, and actually many of these are narcotic users now for musculoskeletal pain or other types of pain. So if you look at all-comer narcotic use, not just for GI abdominal pain, we still struggle with about 40% using some form of opioid at 10 years out. And I think these patients who have been treated for opioids for pain, I see a lot of going back on opioids if they get arthritis, if they have other types of pain. So I think there's some optimization still for opioid withdrawal after the procedure, but patients really perceive a great benefit in terms of pancreatitis pain. So we're trying to figure out how to do better with this population, and one of the ways that we're doing this is we created a multi-center consortium that we call POST, that is for the prospective observational study of TPIAT, and it's a multi-center research consortium. It has now, we started with 8 sites, and now we're up to 12 actively enrolling sites. And the idea behind this consortium is to try to invite every patient who has TPIAT across multiple centers to participate in a study where we are being very systematic across institutions about collecting the same data, including patient-reported outcomes and coordinator interviews at specific time points for things like medication use. And we're also collecting details about hospitalizations, imaging studies, procedures, to be able to do a cost-effectiveness analysis. So the questions we're really trying to address are when is the right time and who is the right patient to undergo TPIAT when we're looking at pain, quality of life, diabetes. And this is funded by the National Institute of Health. So what about the diabetes outcomes after TPIAT? Well, you have heard a little bit about this from Dr. Robertson just before me. This is looking at the patient population, again, kind of looking at some of the same islet mass measures that Dr. Robertson showed you, but we would consider more than 5,000 islet equivalents per kilogram body weight to be a really good islet mass to transplant from someone who has chronic pancreatitis. And when we can get that, we have about roughly 2/3 of patients at 2 or 3 years after surgery off insulin. So when we can get enough cells, we can do quite well in terms of actual insulin independence. When we have fewer cells, we would consider this kind of a moderate number, around 2,000 to 2,500 to 5,000. Those patients are about 1 out of 4, 1 out of 5 off insulin, and where we once in a while but rarely get patients off insulin is if we have a very low islet mass for transplant. So we do want to get more cells when possible. I'm talking about insulin independence here because I knew you'd have some of the C-peptide information, beta cell function information from Dr. Robertson, but I want to emphasize that being on insulin is not necessarily a failure of this procedure. So most of our patients who are on insulin are actually C-peptide positive. Many of them just take 1 insulin injection a day to control their diabetes, many of them with A1Cs in the 5s. So this form of kind of C-peptide positive partial function is a much more manageable form of diabetes, generally speaking, than just taking out their pancreas and having no islet function. So one of the themes, I think you heard a little bit about this morning, but I just want to reiterate, is that if you have someone who is going to likely be a TPIAT candidate, doing another surgery before you get to TPIAT can be detrimental, particularly to your diabetes outcomes. And so you can see these are patients in our population who did not have any surgical intervention before they went to TPIAT. Patients who had a Whipple actually did okay, but once you start getting down to a Pusteaux, Fry, distal pancreatectomy, these patients get about half as many islets, and that has to do with both resection of pancreatic mass in the case of a distal pancreatectomy, but also in the case of a Pusteaux or a drainage, it has to do with the ability to perform the islet isolation procedure because of the disruption of that pancreatic duct. And so this is particularly important for children with genetic disease. We see less of this now, but we used to see a lot of teenagers who would come back to us after having had a Pusteaux as a child somewhere, and then they have recurrence of their pain or ongoing acute pancreatitis because just draining their duct wasn't enough to change the rest of their pancreas. They come back to us for a TPIAT procedure, and at that point, unfortunately, they've both been exposed to more longer duration of pain and narcotics, but also have been exposed to having that surgery where we can't get as many islets from their pancreas. So we do, I think, tend to go to TPIAT in children in particular for that reason. So just a little bit of interesting other data. We talk about islet equivalence, which is an islet mass measure, quite a bit. We talk much less about islet number, but islets are actually different mass, different size. So within the native pancreas, there are small islets, there are large islets. In theory, the large islets have more beta cells because they're bigger, and small islets have fewer, and so it makes sense to measure this as an islet mass, islet equivalence. But one of the observations we do have in the patients who have kind of that marginal islet mass, that 2,500 to 5,000, where they maybe are insulin independent about 25% of the time, when they get more small islets, so this islet size index is basically kind of a rough measure of how big the islets are. When they, in our population of autografts, when they get bigger islets versus small islets, They are much more likely to be insulin independent with small islets or require less insulin. And our patients who have had very large islets in this marginal mass category tend to need a lot more insulin supplementation, have less function. So this is not something we can manipulate. This is really kind of reflective of the native pancreas. But we think in that marginal islet graft group that we just lose too many islets or too many beta cells to hypoxia with the large islet size, and that there is probably a favorable factor in this group in particular to having small islets. So what about insulin independence if we look again now here at children versus adults? So we do see higher insulin independence rates in children, and so if I draw your attention first to this graph over here for insulin independence by age, and this is again the same color coding for children, we see long-term, not necessarily many differences early on, but I'm a very slow insulin weaner. As a disclosure, I think the beta cells do better if they're allowed to really rest during the period of revascularization, so I wean insulin very slowly. And we see over time that our children have a greater rate of insulin independence than adults. But what's really interesting about this, I think, is that this is driven by the really young kids. So there used to be this real hesitation to proceed with TPIT in a younger child, right? Because this is a huge surgery, and understandably, you want to be careful about doing this in a young child. But it turns out actually that the insulin independence rates tend to be the highest in this prepubertal group, and that may be something about the beta cells themselves. That might be something about the recipient. You know, young children in this age group are more insulin sensitive, have lower insulin needs, so perhaps they're putting less metabolic stress on the islet graft during that early engraftment period, but that's been a fairly consistent observation of ours. So it's not because those children are inappropriately off insulin. If you actually look at the A1c levels at 1 year in this population, you can see the average A1c is about 6.2, 6.3 for the young kids, so this is all comers. Those are insulin dependent and those who are not. Our teenagers tend to have an A1c around 7% on average, and that reflects some of the same compliance issues that we see in a teenage diabetic in this population as we see with our type 1s. What is striking, I think, about this is if I put this side by side with the type 1 diabetes exchange, these A1cs, these mean A1cs are much better than the mean A1cs that you'll see in type 1 diabetes in the population. So we are able to really get better glycemic control in this population. So I want to get back to this issue just momentarily about the impact of disease duration. So we have one model, I think, that is relatively pure for looking at the effect of disease duration on the pancreas, and that is the PRSS1 hereditary pancreatitis model. I think it's probably, of what we have, the most consistent of what we have, and now we have about 80 patients who have PRSS1 who have had surgery at our institution. And so we look just statistically, obviously we can't look very well within a single person at this. We don't have arginine stim tests over a 5 or 10 year duration, unfortunately, before pancreatectomy. But if we look statistically at what happens for duration of pancreatitis compared to function of the islets, you can see that, as you would expect, as the duration of hereditary pancreatitis gets longer, the risk of a failed graft goes up. Insulin independence is particularly rare for adults with PRSS1 and those who have had disease for more than 18 years. And statistically, if we looked at the islet equivalents per kilogram and how this changed with time, it was reduced by about 22% for each 5 years of disease. So I typically will tell patients, if you're going to do this, it's not that you have to get in next week. It's, you can get in 6 months or a year, but if you're going to do this, you probably aren't doing yourself any favors in the diabetes world by waiting 3 years or 5 years, because you are slowly losing islets over that time. So a couple unusual events just to keep on your radar. We have seen patients who have gone on to develop autoimmune diabetes after TPIT. Not many. This was our first observation of that a few years back. Just a patient who happened to be in one of my clinical trials. This is an adult patient. Came back, was insulin independent with more than 5,000 islet equivalents per kilogram, came back at 1 year, had these weird blips of glucose of like 300. We'd started back on a few units of insulin, not thinking much of it, and then by 18 months out, her A1c was 11%, and she had no C-peptide at all, and we did some retrospective testing and found that she had developed type 1 diabetes, and we've seen a few others of these cases. So my rule of thumb now is if you see a rapid graft failure, think of type 1. Even more concerning, we have had one case of metastatic pancreatic cancer in the liver that happened after TPIT. And so this was a gentleman who was not genetically tested. He was in his 40s, had chronic pancreatitis, so it's possible he had a hereditary disease we didn't know about. He did great with his TPIT for about 8 months until he came back with new pain, new abdominal pain at 9 months, and liver lesions, and died a few months later of metastatic pancreatic adenocarcinoma that we presumably infused with the islets, even though all of his imaging and his pre-op markers were negative. So if I have someone with hereditary pancreatitis who's 40 or 50 and is coming through thinking about this, I also am very careful to mention this, risk that we don't know if we might have some pre-malignant cells in there that we infuse. So very lastly, I just want to talk a few minutes about the challenges we have in diabetes remission, because we do lose, even though we try to get as many cells as we can, we do lose some of those cells along the way because of the isolation in the transplant process. So there is stress in the islet isolation. We have the instant blood-mediated inflammatory response around the islets, metabolic stress and hypoxia, and all these factors are proposed to contribute to beta cell apoptosis and islet loss after transplant. And this is one of my areas of research that we'd like to be able to facilitate greater survival of the cells we're infusing. How do we know this happens in people? Because we thought it happened because of animal studies, and very recently there have been some beta cell biomarkers that were developed for type 1 diabetes research, and now we know it happens in people because we're actually able to take a blood sample right after their TPIT procedure and their islet infusion, and we can see that these beta cell biomarkers are greatly elevated above baseline in the bloodstream. And basically what these beta cell biomarkers are markers of is beta cell death in particular. So it's a marker of dying islets that we infuse. In fact, this happens even before we infuse the cells. So if we look at these same markers in the media of the bag of islets that's brought back from the OR, and we look at the level of these markers in the lab, and then right as the islets are infusing in the OR, we see that there are already islets dying in the prep at the time that we transplant them. So we are very interested in working with some of the diabetes technology. As an endocrinologist, I'm very interested in closed-loop pumps. What we have on the market now is really just the 670G pump, which has some limitations in what we can do. But what we did a few years ago is we actually worked with one of the companies to develop an investigational closed-loop pump model, very primitive, involved a laptop computer that we could use in the hospital to set an algorithm to our patient population in particular. And so these patients, when they are switched off an insulin drip after their TPIT, we put 7 of them, randomized 7 of them to get a closed-loop insulin pump delivery in hospital, and 7 of them to actually get what we would standardly do with insulin injections. And one of the things that we were able to see is that this is sequential order of average blood glucose. And blue is the closed-loop pump system, and pink is the MDI system, the insulin pen. So what happened is all 7 of the patients who went on a closed-loop pump had tighter glycemic control with less variability than all 7 patients who went on injections. So our goal is to eventually actually translate this to the outpatient setting with some of the approved therapies when they get tight enough to the point that we can use them. Why is that important? Because it improves or reduces the metabolic stress that's placed on the engrafting islets. What are the other clinical trials that are being looked at to improve islet survival? Well, we looked at incretin class drugs, not GLP-1 agonists, but DPP-4 inhibitors. We completed that trial and unfortunately saw no benefit. There are some trials in process with various anti-inflammatory agents, IL-8 inhibitor, TNF-alpha blockade, alpha-1 antitrypsin, both at our center and other centers. There are several places that are looking at alternate sites for transplant, getting back to some of the issues you heard earlier. There are other sites that are looking at some other supportive therapies, and I didn't want to get into this here for our purposes, but I think it would be remiss not to mention that there are some expanded indications being explored in Europe for pancreatic cancer, but not in the US. But of course, our ultimate goal is what we really want to do is benefit the patient. So these are all patients who had a TPIT, kind of going back to living life and having families and going on trips, a lot of the things that people really struggle to do when they have chronic pancreatitis, and so that's really our goal. These patients are a big part of helping us achieve that goal because they're very generous about participating in research. It's a very altruistic population. And we have a great team that works with our program, so this is not quite all of us, but everyone who could be gathered in a picture of our surgeons, gastroenterologists, endocrinologists, nurses, and other people that take care of these patients. So thank you.
Thank you very much, Dr. Molina. It was really a beautiful overview over a field that, I mean, just 10 years ago used to be a new field. And now it's really becoming established with all the plethora of information that we have. It's also, I think, of interest to know for medical students and residents alike that clinical research is important, probably as important as basic science research. Sometimes it doesn't have the glory of basic science research, but don't forget, 80% of basic science research, unfortunately, does not lead to positive results. So clinical research, I mean, like the one that was presented, is extremely important to our knowledge and to the advancement of the areas that we are working in. The second to last speaker today is Jose Oberholzer. Like so many of us, actually the same is true for Dr. Herring, originally from Europe, from Switzerland. Dr. Oberholzer is the director of the transplant program at the University of Virginia. Before his time there, he was a director of Pancreas and Islet Transplantation at the University of Illinois at Chicago. He has been also a true pioneer in many regards. I mean, he will talk obviously about islet transplantation, but as you know, Dr. Benedetti was recently here at Grand Rounds to speak about robotic kidney donation, robotic kidney transplants, robotic pancreas transplants, and it was really Dr. Oberholzer who initiated many of these things and continues to do them now with his new team at the University of Virginia. He has about more than 250 publications to his credit, a lot of intra and extramural grant funding, particularly with the JDRF. There's also one thing I want to mention to you. I mean, you, particularly the younger generation, as you're going into that field, keep your options open and do something else. Dr. Oberholzer is an avid runner, and he told me yesterday that one of these, I can't recall, I mean, which marathon he ran, but he ran it below three hours. So, I mean, for someone at my age, I mean, this is almost inconceivable. But obviously, I mean, he does have many interests outside of medicine. Dr. Oberholzer is going to talk to us today about the current status of auto and islet allo-transplantation.
Thank you very much for the kind introduction and invitation here. I'm actually in this country because of David Sutherland, who had the kindness to recommend me to Dr. Benedetti when they were looking for a transplant surgeon interested in diabetes. And so I moved here in 2003, and it has been quite a journey. So maybe we need to pull that up. Yeah, maybe the next slide. I'm currently a professor at the University of Virginia, but still continue to have an adjunct appointment at the University of Illinois, where I go once a month to see our patients that we have transplanted. Some of them are now over 10 years out. And during my time at the University of Illinois, I also founded a company, CellTrans, that is now manufacturing islet cells for the University of Illinois and pursuing a license application to make this an approved procedure. And last but not least, I'm one of 5 founding scientists of Sigilon Therapeutics, which is a startup company in Boston, and I will talk a little bit about this at the very end, that is pursuing biomaterial research and encapsulation for cell therapies for rare diseases and also for diabetes. So as I said, my disclosures, and the last thing that I forgot to mention is I started about 12 or 13 years ago a foundation in Chicago, the Cellmates on the Run Foundation, that raises research money through marathon running in Chicago and in New York. And we have been supporting groups around the world to do research with small amounts of funding that allow to do the 1 or 2 experiments that the current NIH grant may not cover, or to do the 1 additional initiation of a collaboration that maybe JDRF couldn't fund right away. And this has been quite a journey, and most of the research that you will see actually directly came out of these collaborations. So we will fly through different aspects of beta cell replacement therapy, and I could not impede myself to squeeze in a little bit of pancreas transplantation, because in some ways pancreas transplantation is just a big islet cell transplant. And I would say an islet cell transplant is actually a small islet cell transplant, because in the process of isolating the cells, unfortunately, we lose a significant number of cells. And so for pancreas transplantation, the current indication, we heard that mostly it happens in the context of a combined kidney and pancreas transplant, but there is still room for offering this procedure to patients who present still with normal kidney function but brittle type 1 diabetes. And I think there is a subgroup of patients, in particular those who have a higher body weight or have high insulin requirements, who are really poor candidates for an islet cell transplant that can benefit from this procedure. And historically, those patients have not been transplanted because they have a higher surgical complication rate, in particular because the access in an obese patient with type 1 diabetes is very prone to wound complications, and those are unfortunately not trivial in transplant patients. And you will see a few more recent aspects of how this can be solved. The other aspects, of course, patients who already had a kidney transplant, I always feel they are not very well served with an islet cell transplant because the metabolic demand in those patients is often higher. They are often still on steroids, and islet cells just don't work very well in those patients. And I think they should still be offered a pancreas transplant if the overall risk profile of those patients permit it. And as Dr. Grusin was highlighting earlier today, there is a group of patients who has had pancreatectomies, and you have to realize that still today, 90% of total pancreatectomies in this country are done without an autologous islet cell transplant. I think it's shameful, but it's the reality. And those patients are still out there and could benefit at least from a pancreas transplant if the compliance is appropriate and, again, the overall risk profile permits it. Now, a few years back, we had the same issue as with overweight type 1 diabetic patients we had with kidney patients. In certain areas of this country, about 40% of patients on dialysis have a BMI above 40. And those patients are invariably denied access to kidney transplantation. And the reason I'm telling you this is that we gained some experience in doing something that I think maybe in my residency I would have laughed and thought that the person would be crazy or delusional to think that you could do a transplant procedure minimal invasive. But in 2009 at the University of Illinois, we did actually the first case worldwide of a minimal invasive kidney transplant. And what you see is here, instead of this patient getting a really big cut in an infection-prone area, we used the same cut that they were using for bariatric surgery, which we knew had a very low infection rate, and squeezed in the kidney there, and could also use it to occasionally use this instrument, which is an awesome instrument. It's the hand of a surgeon to pull the bowels away in patients that were very obese. And this was a highly successful procedure. Now, shortly after we did the first few patients, we had, of course, a lot of visitors from around the world coming and watching how we were doing this. And among them was Ugo Bocci, who was a brilliant surgeon in Italy. He's a very technical, very, very skilled surgeon, does a huge amount of Whipple procedures and works in a high volume program. And he did a small series of, I think, 3 cases of pancreas transplant, and his incision was a little bit bigger, and you could criticize, well, that was a halfway open procedure, but it doesn't matter. He did the first cases. And I called him up and I asked him, well, now you have done 3 cases, what's going on? He said, well, I don't think my coronaries can tolerate doing many more of those cases. I'm actually not doing it anymore. And if you want to do this, you have to be really, really committed. And so at that time, then, I looked at the results that we were having, and you have to realize transplantation is one of the most transparent areas in medicine. You can look up on the internet the results of every single program in the United States. And the federal government always calculates for you the expected outcomes and gives you what the average is nationally and compares you to this. And at that time, when we were looking, every 6 months you get evaluated, our kidney graft survival in that group of getting a combined transplant was 100%. And the same was for the pancreas transplant. Year after year, we had a 100% pancreas transplant survival rate and 100% patient survival. And when my boss came and said, well, Jose, I think you should start thinking about doing the pancreas robotically, I said, well, Dr. Benedetti, with all due respect, how can I improve on 100% success? And he said, well, fine, but you should really at some point think about that. And I kind of forgot about it until one day a patient showed up in whom we had done a robotic kidney transplant. And when I told him I'm going to do a big cut to put in the pancreas, he said, absolutely not. You're going to do this exactly the same way you did my kidney transplant. And he escalated this up to the hospital administration, to my boss. And then I was confronted and asked me, well, do you feel comfortable doing this? And I said, well, I'm not quite sure. And I said, well, that sounds good enough, just do it. And so I have to say we were really nervous, and I even asked my boss not to come into the room, and I had one of my preferred residents who was extremely talented, was a fourth-year resident, and I did it with a fourth-year resident. I didn't allow anybody to come to the room. They just had to leave me alone. And we were so nervous that we actually didn't even record the procedure. We forgot to push on the record button. And so we did the operation, and it went extremely well. And the most difficult part was actually to figure out to do the enteric anastomosis. Now, the second case was then a combined kidney pancreas transplant, and this time we did not forget to push on the record button. So this was an over-eager fellow from Taiwan who was very good with the computer and put the entire music. It's actually rhythmically synchronized to the music. So you see, this is a patient, if I remember correctly, at a BMI 46, and you are operating like in a very, very clean field. And I mean, the entire operation is magnified, and you can really suture and sew all those things almost better than I would say than you can do open, considering how difficult it would be to access such a patient. So the only difference for the residents, we use a Gore-Tex suture because the monofilament Pauline suture will break with the robot. And for the enteric anastomosis, we just decided to use a staple device and did then side-to-side anastomosis. Wow, this video is going a little bit too fast, but that's okay. And then once this is finished, we go to the other side and then implant the kidney. And that we had done over 100 times, probably by the time I did this first pancreas transplant. Again, it's a very clean operation. There's very little blood loss to it. The only limitation is, of course, when you have very calcified vessels, it becomes a little bit more challenging to do the clamping of the vessels. So we always perform a CT scan in those patients beforehand just to make sure that the iliac vessels are not completely calcified. And the other aspect is, and I'm not quite sure I included this in video, yes, you can then use ICG to look at the reperfusion of the kidney. It's more of a gadget. Usually, the reperfusion is fine. And then the urethral anastomosis, again, is done exactly the same way we would do this open. So I think you got the idea. So what does that all mean? So we have heard today, I think, a lot of evidence that pancreas transplantation is a highly successful procedure. And I think this minimal invasive approach opens new avenues. We have extended this now also to lean patients. Initially, we were doing this only in obese patients, but we can now use this in lean patients and do essentially a small pun and steel incision to insert the organs. And I can tell you that our nephrologist couldn't quite understand when the first patient came to the clinic and said, well, I got a kidney pancreas transplant. I said, well, show me your belly. And then the nephrologist said, no, you did not get a kidney pancreas transplant. And the patient had to convince the nephrologist, yes, I did, and showed the pun and steel incision. So the caveats are, of course, all those patients always have a trade-off between over and immunosuppression, the side effects of immunosuppression. And so that's why at present it's mostly used for patients who have very severe form of brittle diabetes that don't respond to the sensors and semi-closed loop systems, and of course the patients with end-stage renal disease. Now the other endocrine replacement, the islet cell transplant or the small islet cell transplant, has still a relatively artisanal procedure to isolate the cells. I mean, we are injecting some collagenase and some proteinases, and then we put it in a chamber, heat it up to 37 degrees Celsius, we shake it like a bar mixer, and then we hope some stuff will come out, and then we purify it with density gradients, and of course in all this process a lot of cells are being lost. To make matters worse, once we inject the cells, there is an instant blood-mediated inflammatory response to those cells, and more cells die. So probably most of our islet transplant patients don't get much more than 10 or 20, maybe at most 30% of the islets of an entire pancreas. So the indications are very similar to the pancreas transplant, and I think if there is one take-home message for the residents is, hypoglycemic unawareness is a severe disease, and even with modern sensor technology and closed-loop system, there is still a small subgroup of patients, which we estimate to be around 150,000 patients in the US, who will have a very poor prognosis unless you do a transplant procedure. And the indication ultimately is very similar, whether it's a pancreas or islets, because they will be pretty much on the same medications afterwards. So just because you can do it by a syringe doesn't mean that it's any less consequent in the long term with the immunosuppression. And then, of course, the autologous islet cell transplant should really become standard of care. And I hope that your generation will not allow a patient to have a total pancreatectomy for a benign disease without having that procedure. So in this regard, because we were doing a lot of robotics, we worked closely with Pierre Giulianotti, who is probably one of the foremost robotic surgeons in the world. And we had only very few patients with chronic pancreatitis at the University of Illinois, and often there were redo cases that had previous surgery. So we started first with a robotic-assisted laparoscopic distal pancreatectomy with autologous islet transplantation and reported this, I think, in 2009. And then subsequently applied this also to include the pancreatic head and developed some approaches to that. I have to say it is a painful operation in very advanced disease. I think for the minimal change pancreatitis, I think this is an ideal procedure, but we were not lucky enough to have those patients, so we did it in really hardcore chronic pancreatitis with previous surgeries. And just for historical perspective, for the female surgeons, so Veronica Gorodner is the spouse of Carlos Galvani, and she was actually involved in this, and Carlos Galvani was then the one who, together with Dr. Grüssner, then published the first series of total pancreatectomies. So this was a couple of surgeons that are very, very proficient, minimal invasive surgeons. So it's possible to have two surgeons live together. So again, what does this all mean? So I think autologous islet cell transplantation can reduce the disease burden after a pancreatectomy. And I think the minimal invasive approaches can somewhat reduce the invasiveness of the procedure. I would not want to overemphasize that too much because at the end of the day, the operation inside is still very, very invasive. But at least you can remove some of the abdominal pain in those abdominal wall pain, which in some patients can become like a new issue and a new reason why they are on chronic pain medication. And I think the take-home message here is, again, for the new generation to think about early to refer a patient like this to a program like Dr. Grüssner is building up here or the Minnesota program. I think this is a procedure that shouldn't be done in too many centers, especially if you want to be aggressive and go early in this. Because ultimately what determines the success is how much symptoms were there and for how long they were there. And I think we cannot overemphasize that. It is still shocking to see patients who have had 10, 12 years of medical management before they are being sent to the surgeon. By then, their lives are destroyed, they lost their jobs, they are divorced, they have no health insurance anymore, and so on. It's a whole cascade. So when it comes to transplanting cells from a cadaver islet, it's a whole different story. And it's a whole different story because we enter the world of regulations, and it is under the view of the Food and Drug Administration, because islet cell transplantation isolated from a cadaver a pancreas and transplanted to a different individual is considered a biologic drug. And so this has been a very, very long path to develop that. We had to go through phase 1, phase 2, phase 3 trials. And at the very end, when we said, okay, now we are done, and now we want to get approval for this and do this under insurance coverage, the university I was working at said, no, that's not going to happen. We are a public university, and we are not in the business of manufacturing a biologic drug. And so we were asked at the time to create a company, and that's Celltrans. I apologize, it doesn't project on this Mac slide here on the PC. And so we created that company and rented our own facility, and the vast majority of the team then moved into the company and is now they are now employees of that company. We are renting the same facilities we were using for over 10 years and do the same thing just under the name of a company to provide a liability shield towards the university. So this is still ongoing, and now what we are doing in Virginia is we build a new facility for the next generation of transplant, which I will talk about a little bit over the next few minutes. So an islet cell transplant is in some ways not exactly what we all have trained as surgeons. And when I explained this the first time to my father and told him, well, there's a radiologist that puts a catheter into the liver and then I push the syringe, he looked at me and said, and so you're telling me that you went 6 years to medical school in Switzerland 6 years of residence in Switzerland, fellowship in Canada, and so on. And so now you can push a syringe. And I said, yeah, kind of. So that's the procedure. So the radiologist places the catheter into the portal vein. And you see here a nice portogram with all the small ramifications. And after the transplant, you see that some of the ramifications disappear because they get clogged by the islets that go into the small venules of the portal system. And so as you know, the liver has two vascularizations, the hepatic artery and the portal vein. And if you do flow studies, what happens is the flow in the hepatic artery increases when the flow in the portal vein decreases. So we see a little increase in transaminases, but we never see any changes in bilirubin or no changes in INR. So the liver function remains completely stable. That's a biopsy in a patient who needed a hernia surgery about a year after an islet cell transplant, and we asked him whether he could sneak in and take a little piece of the liver, and he was a funny guy and said, well, for as long as you leave me a little bit of liver left, I'm okay with that. And so we did then those histologies for insulin stain, and we also did some staining for some microvascular endothelial cells with a CD34 marker, and could show that there is a regrowing of vessels inside the islet. And that's the period that our endocrinologists try to bridge by keeping the cells a little bit at the rest. Now, what are the results? And I apologize, this looks a little bit like an infomercial for some hair growth product, no hair and then some hair. So here is bad glucose control, bad glucose control in 2 cohorts of patients. This one was randomly less good than the first cohort, but that's before transplantation. These are all patients followed by our endocrinologists, and I can tell you they were really good endocrinologists. And that's what it looked a year later of insulin. And so when you look more precisely, you see that it's not perfectly normal. The fastings are a little bit higher, but that's pretty damn good for a type 1 diabetic patient, especially considering that they are not taking any more insulin. And so this was those 7 daily blood glucose measurements over a 2-week period, and the whiskers indicate the 90th percentile and the 10th percentile. So 90% of all the glucose values were within that range. Now, Bernard Herring has been a pioneer, or is still a pioneer in the field of islet transplantation, and he put together a consortium together with James Shapiro from Edmonton and Camilla Ricordi from Miami, and we were fortunate enough to be invited and contribute with a few patients to this trial. And once you go to a multi-center setting, of course, the challenges become much bigger because now you have different experience levels and different expertise in preparing those islet cells. And the bottom line is that if you expand this to a number of centers, you can achieve a success rate that is close to 60% at 1 year, but unfortunately drops off after 1 year in terms of insulin independence. But the end goal of this trial was to keep the hemoglobin A1c below 7% and not have any hypoglycemia, and that was achieved in the vast majority of patients. When you go to a single center experience, and Bernard could show exactly the same results and several other experience centers, then you get to a 5-year result of about 60% insulin independence. And of course, when you are not in a trial like this, you can also add islet preparations to patients in whom you see that the hemoglobin A1c starts climbing. You can retransplant them before they have to restart insulin again. And that is very successful. That really helps those patients to stay off insulin for many, many years. And so we are following now smaller cohorts that are beyond 10 years, and you can achieve those results with not too massive immunosuppression. Actually, we feel that for patients who are not pre-sensitized, you can achieve that without the need to deplete T cells like we used to do in most patients that received either an islet or pancreas transplant. What I personally found the most impressive is that how you can maintain stability on those patients. And again, it's not perfectly normal. I mean, today we would like to have a hemoglobin A1c of less than 5.6%, but be hovering around 6% is really, really good. And when you look at metabolic stimulation in those patients, again, you see that the fasting blood sugar is not totally normal, but you still see a very, very significant insulin and C-peptide response here, just an example to a mixed meal test, 10 years after this was a single islet cell transplant. Again, what does that all mean? So I think islet cell transplantation, allogeneic islet cell transplantation, either in form of a pancreas or an islet cell transplant, can functionally cure diabetes, at least in a small cohort of patients. And for those patients, they feel like they are cured. And you realize that when their graft fails. I've had recently a patient who was 11 years off insulin, and the patient was sobbing and said to me, I can't even remember anymore what I had to do when I was a diabetic, because 11 years is a long time, and then having to go back after 11 years of being free of insulin, just the reaction of that patient indicated that they really feel like they are cured even if they have to take immunosuppression. Again, the same trade-offs in terms of using immunosuppression. So when will islet cell transplantation become widely available? So there are several programs now that have what we call expanded access. That's a program that the FDA created for clinical products that are not approved yet but have shown efficacy. The problem is most insurances deny it. And I think, Bernard, you have had a couple of patients that you could do like that, and I think UCSF has done a few. And so it is available, but probably insurances are the biggest impediment right now. And licensure of the islet cell product is now being pursued by several academic medical centers. But until reimbursement would kick in and until Medicare can be convinced to pay for this, it's at least another 2-3 years. I don't know, Bernard, am I too pessimistic, or I think this is a realistic appraisal. So now what are the problems to be solved? And I just would like to use a couple of minutes before I end to talk about how we could provide much more cells to all the patients in need and how we could protect those cells without the need of immunosuppression. And of course, I could keep on talking for several days to cover this entire field, so just a few snippets on what's going on right now in the field. So the next generation islet graft has to address the question, how can we have an unlimited source of cells? And so there are a number of people that are trying to identify stem cells in the adult pancreas, or to identify some cells that could give rise to new beta cells or new islet cells. And there are groups that are also pursuing to make the existing beta cells proliferate. This is a very difficult field. That's my own pet project now for almost 20 years to make beta cells proliferate. And while proof of concept is done, we don't have yet means that would be safe enough to be applied in patients. The other areas, of course, stem cells, be it embryonic stem cells or inducible pluripotent stem cells, there is a massive explosion of research in this. Many academic institutions are working on this, many startup companies. And then last but not least, xenogenic sources. In case of insulin, would make the most sense to use pig islets, because pig insulin has been used for many decades before a genetically engineered insulin became available. And so the role of my research team has been essentially to support those different teams in identifying what is a normal functioning islet. Because when you generate new islets, that is not that trivial of a question. And people working in this field often are not experts in islet cell physiology. And because we were working a lot with human islet cells, we really knew how to test them, we knew how those cells should work. And so we could establish a number of collaborations where we helped people to do this. And for this purpose, instead of using animal experimentation, we developed biochips that allow us to mimic the conditions in the human body and apply different drugs to block certain channels or block certain ion flow or investigate how certain organelles like mitochondria would behave. So we can essentially do visual biochemistry real time in a dynamic manner at very low cost. And the person who developed this was actually Adeola, who had a bachelor degree in computer sciences and then came to us to do a PhD in bioengineering. And she came up with this concept and developed that during her PhD. And it has been very widely used now and supported by the Juvenile Diabetes Foundation as a core facility. And just to give you some snippets of collaboration that were possible out of this, so there are groups that have been working on converting, for example, alpha cells into beta cells with the idea that if this would be possible ex vivo, one day we could go into a patient with type 1 diabetes and convert their alpha cells into beta cells, because type 1 diabetes does not destroy their alpha cells. And so this is possible at a very small scale in a small Petri dish, and we could show that those cells actually function exactly like normal human beta cells. Other groups have used cloning approaches, where nuclear transfer was done in stem cells, and so you could create patient-specific beta cells, and again, those beta cells were very close to normal human islet cells. And then, as I mentioned before, there's a whole field working on recapitulating what happens in the development biology, and essentially start from a stem cell and then create beta cells out of this. Now, all this at some point will give us some cell sources. Another question is, how can we do this if we don't want to use immunosuppression? And I don't want to vilify immunosuppression. I'm a transplant surgeon and I use it all the time. I think there is room for approaches where immunosuppression would be part of the treatment, but of course, ideally, this would be avoided. And one approach that we have been working with a number of people around the world is to immunoprotect the cells with biomaterials. And so the two principles for the students and residents, you can either microencapsulate them or you can put them in a larger device. The larger device would have the advantage that you can remove it, and this has some physical advantage in terms of diffusion distance and engineering, freedom of engineering. Now, the problem of any biomaterial is summarized here by Matt Buckneck, who was a PhD student in Chicago, is now at MIT. And essentially, well, you need to have the right cells. The cells need to be able to survive in the biomaterial, have enough oxygens and nutrients. The biomaterial has to prevent adhesions of proteins that can lead then to cellular overgrowth and fibrosis. And so this has been notoriously a problem with all biomaterials. You cannot put anything into the human body without getting a foreign body reaction. And so we have been working on this for a very, very long time, and our hypothesis was that the major contributing factor to losing the cells in those capsules, and Dr. Grüssner knows that this has been around for 3 decades and has been extremely frustrating that nobody could make this work. And we postulated that we have to make sure that the surface remains free of any adhesion of anything, otherwise the cells cannot survive in there. And so, of course, like in science, like the FDA has this little thing on their door and says, in God we trust, all others must bring data. And I think this couldn't be more true than for the field for encapsulation, where lots of claims were made, but data was not generated. So we had a collaboration with MIT and the Harvard Stem Cell Institute over many years now, and very systematically approached the question of the design, what is the size of the capsule, does it matter, does it impact overgrowth, and then went on a journey on screening chemically modified natural molecules like alginate, and then identified a group of molecules that could prevent foreign body reaction. And once we had those biomaterials, we had to make sure that cells can survive in it, and used stem cell-derived islets from Doc Melton at Harvard. And then last but not least, we had to make the jump from doing that research in mice to a clinically relevant model and test this in non-human primates. And we were discussing the implant side, and the implant side was very important because the foreign body reaction is very different from body side to body side. And ultimately, and this is the last article that made it to the cover page in November of Nature Biomedical Engineering, we used an approach where we put the cells in the bursa ommentalis. Essentially what we did is, like at the very beginning of any pancreatectomy, made a very, very small incision in the bursa ommentalis, introduced the catheter, and infused the cells behind the stomach of those animals, put the animals a little bit upright, and then by sedimentation, the cells went into the bursa ommentalis. And so what you see here are capsules containing allogeneic monkey islets in a monkey 4 months after implantation. And you see that there is no overgrowth. The capsules are completely transparent, and those cells did not reject. We did not give any immunosuppression to those animals. So this ultimately, all those findings ultimately led to the creation of a startup company out of MIT. It's called Sigilon. And of course, when you start an endeavor like this, you know that there will be a tremendous cost to bring this to the clinic. And our Chicago Diabetes Project surely could not do that. There were not enough marathons around the world to raise enough money to do that. And so we started getting a little bit desperate, and I like this quote by Nelson Mandela, that always seems impossible until it is done. But believe it or not, the most unlikely partner, I never would have believed that that company would ever support this kind of approach. But last year, we were able to close a deal with Lilly over $500 million, that they are investing now in bringing this forward to the clinic. So money does not guarantee success, but it surely does not impede it. And so we will see how far we will get with this concept. So I think in summary, we can say that we demonstrated the proof of concept that there are human islet cell generation possibilities and expansion possibilities, and that we can encapsulate the cells, at least in a non-human primate model. Now, I have to say the non-human primate model does not have type 1 diabetes, so that's something that we will have to test in humans, but at least we could make the proof of concept. And so the current tactics is we will continue to do cadaver islet cell transplants immunosuppression, and we would like to use the same cadaveric islets to do an encapsulated trial with no immunosuppression, and then by then, we hope that the renewable cell sources are advanced and safe enough that they could be used for this approach. So I would like to thank a lot of different funding agencies for having supported all this, and there are numerous researchers behind all this. And if anybody of you wants to run a marathon, look us up on cellmatesontheRun.com. We do run the New York Marathon. If you want to have a spot, I think we have 1 or 2 spots left, and you can raise some money for diabetes research. So thank you very much for the invitation.
Thank you, Dr. Oberholzer, for a fantastic talk. 2 things. He tried to tell me yesterday that if I want to run a marathon, which I have never done in my life, it would take only about 2 years. I looked at him and I said, you know what, you don't know how old I am. It would take at least 10 years to get there, and even then I'm probably not going to finish it. But also to the generation of medical students that may consider going into surgery and have not made up their mind, there's much more to surgery than just being a plumber, as we are sometimes considered by many. This really shows, that you can be a surgeon scientist, because Dr. Oberholzer does liver transplant, does intestinal transplant, and has been instrumental in developing, obviously, great surgical techniques, including, obviously, the robotic surgery. So I think it's a very exciting field that he has covered with the encapsulation and so forth. He has to leave, and I don't think he realized that LaGuardia is not just a mile away from here, and at this time of the year it takes time. So he has to leave basically right after his talk. But I wanted to take the opportunity and see if there are any questions for Dr. Oberholzer. Phil?
Yes, I have a question. When you have a patient with chronic pancreatitis and refractory pain that you're planning on doing a total pancreatectomy on, when they're already requiring insulin, how do you decide when it's worth doing an islet cell transplant versus when their pancreas is probably so burnt out that you wouldn't get any islet? Is there an insulin cutoff? Is there some sort of lab test?
So personally, what I do is I do some stimulation tests. So the easiest to do, the quickest that you can do is the glucagon stimulation test, that you can do in the clinic on the spot. And if I don't see any increase in C-peptide production in the glucagon stimulation test, then I personally have a really hard time justifying to take the risks of an islet infusion, because then I think that there's not much you can expect from that coming out. Others may do an oral glucose tolerance, and if they are totally diabetic, there's not much C-peptide production, no increase, then I think the use is questionable. I don't know what your view is. Your view is probably any islet is better than no islet, but...
More or less, we do not do it in someone who has low peptide. So we test. It's okay, otherwise I'm loud. We actually, our protocol would be if someone comes in with diabetes, we test their C-peptide. We also look at glycemic control, because we have had a few patients who had C-peptide positivity that we thought was fairly significant, but they were so poor at controlling their diabetes, they just lost those islets after we transplanted them anyway. So we look at glycemic control, C-peptide, and make a decision. Generally, if the C-peptide is less than 2, we just don't even bother to do it. We've seen if C-peptide is greater than about 5 stimulated, we've seen benefit. And then there's kind of this gray zone in between that, honestly, we're a little unsure of what the best route is for them, but we will oftentimes err on the side of doing it. That's, yeah, generally our. That's a really good question. I guess to some extent, yes. We don't get a lot of pediatric patients who are already diabetic, so they're mostly adults. Some of the patients, and they're usually middle-aged or younger adults. If we have a patient who's an older adult and they're already diabetic, a lot of times they'll have a dilated duct, and we actually will go to the conventional Pew-Stowe procedure just because they have kind of so many things going on at that age. So I guess the patients where we're even considering this tend to follow in a fairly narrow age spectrum, so that hasn't come up a lot. But yes, I think younger patient, we might be more prone to do that. And the other caveat that I didn't say, but I should explicitly say, is we test for beta cell antibodies. If they have autoimmune diabetes, then we're not going to infuse those islets either if they're already diabetic.
Antonio and Dan.
What's the role of the microenvironment at the level of the liver to create a favorable environment for islet cell transplant? I'm talking about in terms of macrocytosis and capillary cells. We know that the pro-inflammatory status is the most important factor that creates rejection or induce apoptosis in cells. Mauro Ferrari, the use of methods developed the new microfibers, nanoparticles, just to protect the cells, but it's not developed for islet cells.
Mm-hmm. So that's actually an excellent question. So one observation that we all make is when you do an ultrasound on those patients, or even better, an MRI, you see actually patchy macrosteatosis. So that there is a little bit of fatty degeneration of the hepatocytes around the islets, and it's probably due to local increased levels of insulin. Now, whether this has any pathological meaning, we don't know. I mean, we haven't seen any like steatohepatitis or liver cirrhosis develop in any of those patients. And whether it's harmful to the islet cells, there's no way for us to know that. Now, the liver is a pro-inflammatory environment. I can tell you, if you put microcapsules intraportally, you have a massive foreign body reaction. I mean, much more than you would have in the peritoneal cavity. That's one of the reasons that we completely abandon the intraportal side for microencapsulated cells.
Dan?
I was just going to ask about how many times you can inject these people, because as you showed, you start to see loss of kind of the little offshoots of the portal vein.
So personally, in our series, we have not done more than 3 subsequent. So the most we have ever done, and we have only done this in 2 patients, were 4 islet infusions.
And then I saw that some people have started transplanting the animal models like the iliac crest and other bony sites. Auto-islet transplantation, is that something that's done for allo-islet transplantation once they've already had 2 and they still require, or still poorly controlled?
So I may have to refer to you. The only other sites I know is, so there have been intramuscular autologous islet cell transplant, and then there was a group, I think, in Poland that has done some submucosal infusion into the stomach. Bernard, do you know any other sites that have been tried clinically? Omentum, yeah, Omentum.
Very good. Thank you very much, Jose, for that brilliant talk. Last and not least is a good friend of mine, Bernhard Hering. We met for the first time, I think, over 30 years ago. Dr. Hering at the time was finishing his residency in Germany, little university town close to where I was practicing at the time. But his 2 chiefs were Konrad Federlin and Dr. Bretzel. And they really became, aside from David Sutherland, the leading figures in islet transplantation in the 1990s. And obviously, Dr. Hering took it from them and continued to be probably the most eminent islet researcher, not only in the country, but possibly in the world. There is also a history with regards to that Dr. Hering came to Minnesota even before Dr. Robertson became chief of endocrinology there. The predecessor was Dr. Frederick Goetz, who started, diabetes endocrine research at the University of Minnesota in the 1960s, early 1970s, along with Drs. Sutherland and Najarian. Dr. Herring is currently a tenured professor and holds an endowed chair at the University of Minnesota. He's also the director of the Schulze Best Buy Schulze Diabetes Institute, and has contributed tremendous work to the literature with over 300 publications. He has received numerous NIH and JDRF grants. The list goes on and on and on, but he also has to catch a flight soon, so I don't want to drag on here. But he's going to talk to us about cell therapy for diabetes. Bernhard, welcome to Downstate.
Thank you, Rainer, and thank you all for your patience. This afternoon, I wanted to echo what Rainer said. We have been good friends for many years, and I think it is fair to say that you have been very instrumental in moving to Minnesota. You helped really recruited me, and my professional career would have been entirely different without your involvement. I also wanted to say that I hope you walk away at the end of the day with the impression that this is a very exciting and transforming time, not only in diabetes and in transplantation, but in medicine. And I think when I was asked what a title could be, and I thought maybe we should talk about cell therapy for diabetes, and I will also talk about cell therapy for tolerance. And you know, cell therapy in oncology has taken off tremendously, and then companies have been formed, and within 5 years were sold for $12 or $15 billion, and showing really the tremendous potential associated with cell therapy. Cell therapy can be very, very complex for those who develop it and practice it, but for the patient it is a very powerful and very safe new treatment modality. So I will talk about cell therapy and try to add a few new points to what has already been mentioned earlier today. So here's my disclosure slide. I have a financial and business relationship with a biotech company called Diabetes Free. And I will talk about 2 phase 3 clinical trials that have been done in the field of cell therapy for diabetes, and then discuss new opportunities in immunosuppression-free islet transplantation, and discuss cell sources that are being developed to provide cells on an unlimited basis for transplantation. And this is the phase 3 trial that was reported now a few years ago, the very first phase 3 trial of any cell-based therapy for diabetes, and was important for this reason. It was conducted by the Clinical Islet Transplantation Consortium, and there were 8 clinical and manufacturing sites and 1 coordinating center participating in this initiative. And the objective of this study was to determine the effectiveness and safety of a standardized human islet product in type 1 diabetic patients in whom impaired awareness of hypoglycemia and severe hypoglycemic episodes persisted despite optimized medical treatment. And this condition was selected as one that presents a significant unmet clinical need, and about 20 to 30% of people with long-standing diabetes become unaware of hypoglycemia and are at high risk of severe hypoglycemic episodes. So this study was designed as a phase 3 study, and interestingly enough, it was a single arm, not a randomized clinical trial, because the FDA thought really superior outcomes in this group of very challenging patients are very difficult to achieve. And if you do so, I think it will be so obvious, and randomized control group will not be required. So patients received our investigational product, and the product were human islets. And patients also received anti-rejection, prophylaxis, induction therapy with a polyclonal T-cell antibody, and maintenance with sirolimus and tacrolimus, and also anti-inflammatory protection with etanercept, a soluble TNF receptor. So pretty strong and potent immunosuppression. And our patients all had type 1 diabetes with negative C-peptide and episodes of severe hypoglycemia in the history, and documented reduced awareness of hypoglycemia. And a severe hypoglycemic episode in our trial was defined as an event that required assistance of another person to actively administer carbohydrate, glucagon, or other resuscitative actions. So, or in other words, an acute life-threatening event. And patients with type 1 diabetes, when you talk with them, fear severe hypoglycemia more than blindness or more than any other complications, because they know about the dead-in-bed syndrome and other very concerning complications associated with severe hypoglycemia. And many suffer from problematic hypoglycemia, which is a condition in which these episodes are completely unpredictable, cannot be easily explained or prevented, cause major fear and maladaptive behavior, and therefore have a substantial negative impact on health and quality of life. And then we discussed with the FDA what an appropriate and clinically important endpoint could look like. So it was not insulin independence. So in this particular population of patients, what was really finally agreed upon was the endpoint, a composite endpoint, the proportion of patients with near normal hemoglobin A1c levels and free of severe hypoglycemic episodes at 1 year after the first islet transplant. And this is a outcome that cannot be accomplished in more than 5% of patients who meet those criteria with the most advanced medical therapy. And then we see at baseline, none of the patients met the endpoint, and then we had close to 90%, and at 2 years, 80% of the patients were meeting the endpoint. And then when we look at the individual components, so hemoglobin A1c became normal after transplantation. You see here the median levels, and the percent of patients with severe hypoglycemia was 100% at baseline, and fell to less than 10% or even 5% post-transplant. So very rarely in clinical medicine do you see black and white differences like shown in this study. And then the number of episodes of severe hypoglycemia is shown here before transplantation. So the median was about maybe 20 or 30 acutely life-threatening events in the year before transplantation. And this problem was more or less eliminated, completely eliminated after transplantation. The Clark score is a measure of awareness of hypoglycemia. When the score is high, like 7, patients are fully unaware of hypoglycemia. And as you see, most patients had a very high score, and then the median score was 0, both at 1 and 2 years after transplantation, indicating that the patients became aware of hypoglycemia again. Patients were not insulin independent as often as in previous studies, because also insulin independence was not a primary endpoint, and also patients were not supposed to get a second transplant before day 75 or day 270 after the first transplant, which limited the opportunities for a second transplant. But when you look at the insulin use in units per kilogram per day, you see that insulin use dropped significantly, and the median use was very low at 1 and 2 years post-transplant. So there were very few serious adverse events, procedure-related, immunosuppression-related, and a few episodes of hypoglycemia. But none of these serious adverse events resulted in death, disability, or permanent residua, and none required expedited reporting. So that indicates, in contrast to many other clinical settings, including also whole organ transplantation, the safety results were fairly favorable in this population of patients. There were other adverse events. 6 subjects had panel reactive antibodies post-transplant, but not before, and 1 subject had acute kidney injury, which almost completely resolved, and initiation of immunosuppression was associated with a drop in GFR, and as expected in patients treated with calcineurin inhibitors, but there was no further decline in GFR as we know now. So a second study was done by our European colleagues, and this was a randomized clinical trial, and that was reported in Lancet Diabetes Endocrinology last year. And 50 patients were randomly assigned to islet transplantation or control, and patients, again, with severe hypoglycemia and impaired awareness of hypoglycemia, and also islet after kidney patients with poor glycemic control. And the primary efficacy outcome was a proportion of patients with a modified beta score of 6 or higher. And what is that? So that is a composite score that gives 2 points each for 4 outcomes. Fasting blood glucose being normal, hemoglobin A1c being near normal, positive, clearly positive standard or basal C-peptide, and absence of insulin or other hypoglycemic drugs. And a score of 6 or higher is defined as success. And if you see you are on insulin like before, or your C-peptide is negative or less than 1, you get 0 or 1 point. So a score of 6 indicates pretty good function. And what is shown here that the score was very low before islet transplantation and improved substantially. The median score was higher than 6. And in the control group that was given insulin, there was a slight improvement, but a much less profound improvement. And there were several other outcome measures that were studied, and transplantation really resulted in substantial improvement, like insulin use here, or C-peptide, of course, was only improving in the islet recipients, and median hemoglobin A1c improved greatly in the islet recipient group, but not in the insulin treatment group, and the proportion of patients with the CRT-07 endpoint here was 80% at half a year after transplantation. And other endpoints also showed the importance of the islet transplant. There were bleeding complications, like in the other study, in a few patients, and a decrease in GFR. So matching pretty much the outcomes seen in the CIT-07 study. So in addition to those two only phase 3 studies to date, we have information from the Collaborative Islet Transplant Registry, and I want to share with you some new results. And a study was conducted to look at factors associated with favorable 5-year long-term outcomes in transplantation. The phase 3 studies had much shorter follow-up. And 398 recipients with type 1 diabetes and severe hypoglycemic episodes with negative baseline C-peptide were enrolled in the study, and primary efficacy outcomes were analyzed against each of all available characteristics, graft, patient, as well as immunosuppression and procedure-related serious adverse events. And what was found was that only 4 factors were associated with, we looked at altogether 7 different efficacy outcomes. And those were factors like recipient age, 35 or older, islet mass infused, more than 325,000 islet equivalents, induction immunosuppression with a T-cell depleting antibody and or TNF-alpha inhibition, and maintenance with both an mTOR inhibitor and a calcineurin inhibitor. And 126 of the 396 patients met all 4 factors. So now what I found was pretty remarkable. When you look at those 4 factors that are fairly easy really to meet, 96% were free of severe hypoglycemia 5 years later. So that is really black and white. Patients had 20, 30 episodes of severe hypoglycemia per year before, and then for 5 years, regardless of the survival of the islet transplant or the function of the transplant, were protected. 73% had near normal hemoglobin A1c at 5 years, 71% met the composite endpoint, and 49% were insulin independent. So now at several centers, we were the first to report favorable long-term outcomes, but now this can be achieved, and this is matching outcomes in pancreas transplantation alone as reported to registry. But I think this is, I must say, this is a select group of patients, and in contrast to pancreas transplant outcomes. But also equally important, the incidence of procedural and immunosuppression-related serious adverse events per patient that resulted in sequelae, disability, or death was extremely low, was just 1 in 100 patient years, or it was 0.056 per patient. So that is indicating a very favorable safety profile. And I think this is important when you compare this with the safety and the quality of life associated with severe hypoglycemia, because this condition affects all aspects of life. It can disrupt everyday activities such as driving, work performance, leisure pursuits, and sleep. And it can have a profound impact on careers, confidence, personal relationships, and so forth. And can cause embarrassment, employment discrimination, loss of employment. So it is a very substantial unmet clinical need. So causing often other problems like cognitive impairment, coma, seizures, cardiac arrhythmias that could be associated with a death in some of the patients. So yes, there are new diabetes technologies like pumps that are sensor augmented, that are driven by a sensor that and an algorithm that can predict low glucose levels and can suspend the pump, and very good hemoglobin A1c levels have been reported. However, it is important to emphasize that patients who suffer from severe hypoglycemia are more or less often excluded from participation in those studies. So the technologies have been validated maybe in patients with much less challenging forms of type 1 diabetes. And there was a meta-analysis done not too long ago, and of the thousands of studies, only 43 were identified that looked at outcomes in those patients, and many looked at educational interventions. 11 evaluated diabetes technologies and 5 pharmacological interventions. So that is indicating that much more work needs to be done in this patient populations. And none of the interventions that were tested were effective in all patients. And for interventions to be effective, patients had to accept an abnormal hemoglobin A1c level of 8%. And awareness was at best only partially restored. So if you ask the question, if patients have access to every single new diabetes technology and a structured education program and new diabetes analogs and close contact to a very experienced diabetes center, what proportion of patients will benefit? And I think this study was done at King's College in London, and 47% of patients did well and hypoglycemia resolved. But in 50% of the patients, this was not the case, and 25 required a pancreas or islet transplant, and another 1/4 of the patients were still being treated. So 25% of patients with severe hypoglycemia may only benefit from a transplantation. So I think that is why when you ask the question, if a patient is in your office with that condition, with a severe hypoglycemia that persists despite the use of structured education, use of all kinds of diabetes technologies, and frequent contact with a diabetes care center. So what are you going to offer to this patient? And I think you could say, well, there are two options. One is, and which is an untested option, and do more of the same. Continue with diabetes technologies and test different programs, and of course very frequent contact with an expert diabetes care team. Or option 2 would be to consider an islet or a pancreas transplant with immunosuppression. And what are the anticipated outcomes if you do this? So I think option 1, the outcomes are unknown because nobody has studied long-term whether patients do well when you continue with the very same treatment that basically has failed. And I think the outcomes are unknown but expected to include recurrent severe hypoglycemia, persistent unawareness, elevated glycemic targets are required, substantial morbidity resulting from severe hypoglycemia, risk of arrhythmia, seizures, injuries, and death. And I think that is what you can expect. And when you look at option 2, transplantation, which is tested and has been studied with outcomes over 5 years, So anticipated outcomes are protection from severe hypoglycemia, restoration of awareness, near normal glycemia, and yes, decreased but still normal GFR, and a low risk of infections and malignancies. So I think we don't know, there has been no randomized study, but I think this would be a fair, really, question to ask, and I think we should really partner and have an integrated diabetes care approach where endocrinologists and transplant endocrinologists and transplant surgeons meet and discuss best options for patients. So this is really the current status and what is next and what is missing. So why is transplantation not being considered more often? I think the results look pretty good to me, but we don't find many colleagues like Dr. Robertson in endocrinology who really embrace transplantation. So what I think is the most significant concern, and I think it is immunosuppression. I talked to one patient and she considered transplantation, and she summarized her understanding, her perception, or her anxiety when she said, I prefer the devil I know over the devil I don't know. And she knows the devil associated with diabetes, but was reluctant to commit to the risks associated with immunosuppression. I think that is how many patients think, and maybe also how many endocrinologists think. So transplantation tolerance is defined as the specific absence of a destructive immune response to a transplanted tissue in the absence of immunosuppression. That is what would make a big difference. Now, it would be associated with better overall health, better allograft survival because they are no longer using diabetogenic immunosuppression, absence of rejection. You would not need to retransplant because the islets and graft much better in the absence of medications like mTOR inhibitors that interfere with revascularization, less impact of non-compliance and lower costs. So that tolerance can be achieved, was shown now 66 years ago by Peter Medawar in an article published in 1953 in Nature, and he showed actively acquired tolerance of foreign cells in mice. And everybody thought at the time, well, it might take a few years, but not much longer. And we will be able to offer this to patients. And you see, he showed this before the first kidney transplant had been performed at Brigham and Women's Hospital in the 50s, but between identical twins, because immunosuppression was not available, or at least not any effective immunosuppression. And now generations of people have pursued the holy grail of tolerance, and it proved to be very difficult. And a number of different strategies have been considered, and Dr. Oberholzer talked about encapsulation because he has really committed his research career to encapsulation. We have been working lately for the last 10 years very intensively on a concept called negative vaccination. And what that is you would administer donor antigen, and this is now here given in form of splenocytes that are made apoptotic by a chemical complexing agent referred to as ECDI, and you give a number of cells 1 week before and 1 day post-transplant. Then you perform an islet transplant. So this was done in mice. And then in the absence of any immunosuppression, mice became tolerant and accepted the transplant without any immunosuppressive medication ever administered. I thought it was pretty striking, and we partnered with colleagues at Northwestern in Chicago, and were funded by NIH to test this concept in non-human primates, because that is our preclinical model that is stringent and so much more predictive of outcomes. And when we studied this concept, we learned that when you treat apoptotic donor leukocytes with ECDI, they become apoptotic, and when you infuse the cells, within minutes, they become removed from the circulation by the splenic marginal zone by antigen-presenting cells. And the uptake of apoptotic bodies makes the cell, the antigen-presenting cell, resistant to activation or maturation, and the cell now becomes a cell that releases massive amounts of IL-10 and expresses inhibitory molecules such as PD-L1, and the complete repertoire of donor antigen can still be presented to the quiescent immune system by those immature antigen-presenting cells. You can also, it has been shown, you can deplete T cells, you can energize T cell, and you can induce regulatory cells and different regulatory cell subsets with this technology. So then we have now written up this work, and it is in final revision, and I think it is the first evidence of non-chimeric consistent allotolerance in non-human primates, and not non-chimeric indicating that no simultaneous bone marrow transplant was required to establish a tolerance. And the way we approached this was a donor. We retrieved the pancreas, isolated islets, kept islets in culture for a week, and transplanted on day 0. And then from the same donor, spleen and blood were prepared and were modified and were turned into apoptotic cells, which were infused on days -7 and +1. And then we used immunosuppression for the first 3 weeks post-transplant, but not any immunosuppression beyond that day. And then I just share a few results, but we were now very pleased to see that we could restore normal glycemia, and on day 21, all immunosuppression was stopped, and the animals remained perfectly normoglycemic, and hemoglobin A1c levels became and remained normal. C-peptide was very robust. Animals gained weight and maintained normoglycemia regardless. Was very strong C-peptide responses at every post-transplant visit in response to IV glucose, good glucose disappearance in IV GDT, here an islet in the liver without any evidence of mononuclear cell infiltration or antibody deposition. And here you see an islet in the native pancreas stained for insulin, and is negative, indicating that remission of diabetes was not accounting for metabolic control. So I think that is something that will change our practice of transplantation of islets, if we can translate this to the clinical setting. But I think in the last 2 or 3 slides, I want to discuss briefly cell sources. And Dr. Oberholzer already talked about renewable sources briefly. I want to talk about xenotransplantation. And I think we have been working on this for many years in preclinical models, and I'm summarizing many years of research. And now this shows complete and sustained reversal of diabetes in non-human primates that receive porcine islets. And I think This is important because it opens many opportunities, and porcine islets could be available as an unlimited source for transplantation. And this was achieved with an anti-CD154 sparing immunosuppressive regimen. And when you look at 1 year post-transplant, again, here in a xenotransplant recipient, perfectly intact islets without mononuclear cell infiltration. And work has been done with genetically engineered islets, and we have a CRISPR program, and we generate many new genetic lines, and we don't know to what extent this will help us, but clearly this presents tremendous opportunity. Others have worked on macroencapsulation using a chamber that is oxygenated, an oxygenated macroencapsulation device where you have islets behind a membrane, and then you have a central oxygen module that can be accessed through the skin and can be refilled with oxygen at least once weekly. And when that was done in non-human primates, and pig islets were transplanted without any immunosuppression, there was clearly improvement in glycemic control, and when the device was explanted, glucose control was lost, suggesting that this technology could be further developed. And clinical research has been done with encapsulated neonatal islets by the Otsuka group. So this is in clinical research already. And what was found was that it was a very safe treatment, but there was no direct evidence of biological activity, even though hemoglobin A1c was maintained at a level of less than 7, with reduction of hypoglycemia in this cohort of patients studied in New Zealand. So with respect to stem cell-derived islet sources, I think there have been remarkable technological advances in the past few years. And pancreatic progenitors have been tested in clinical trials in type 1 diabetes, and now more differentiated beta-like cells have also been generated, and there were important reports in 2014 by Doug Melton's group and also by the group at Betalogics at the time. However, only up to 30% of cells were actually differentiated beta-like cells. And the insulin secretory capacity was 4 to 5 times lower compared with primary beta cells, and they fail to terminate insulin release when glucose levels are lowered, so which is not going to be very helpful when you consider use of those cells in people with hypoglycemia. But importantly, the teratoma risk appears to be very low, if not absent, with those cell products. And induced pluripotent stem cell technologies have also progressed, but robust manufacturing protocols are lacking that are effective across multiple cell lines retrieved from different donors, including type 1 diabetic candidate recipients. I think in 2019, just a few weeks ago, I think a remarkable breakthrough has been reported by Matthias Hebrock and his group at UCSF in Nature Cell Biology, and what he and his group were able to show was that clustering of immature beta-like cells can form enriched beta clusters, a term that he coined, which resemble primary adult human beta cells by physiological transcriptome and functional analysis. So they show very robust dynamics of insulin secretion. They terminate insulin secretion when glucose levels are lowered. And these EBCs display glucose-stimulated insulin secretion as early as 3 days after transplantation in mice. So this is a fascinating new development. Whether this will be scalable is going to be an important question, but it is a major contribution to the field. So the final slide, I want to summarize. I think this day has shown that islet transplantation has established new efficacy benchmarks in type 1 diabetes that cannot be matched by any diabetes technology or medical approach, and is very effective even in the most challenging subgroups of patients. And the recent phase 3 trials in transplantation of human islets have created substantial momentum for scalable beta cell products, with xeno as well as stem cell derived islets being very promising. And finally, protocols that remove the need for chronic immunosuppression will greatly increase results and applicability of beta cell replacement in diabetes care. I wanted to thank NIH and JDF for supporting our work, and all our colleagues, including Milena, Bellin, and many others who over many years have contributed to the work that I presented. Thank you very much.
Thank you, Dr. Beharing. May I have the other presenters also come to the podium? I know Dr. Lee and Dr. Herring have to fly out at 6:30 from JFK, so we may have 10 minutes to ask a few questions and wrap up. You covered a tremendous field, Bernhard, with regard to stem cell augmentation of beta cells, bioengineering. If you had to predict the future, and there was one vice president who once said there's nothing harder to predict than the future. 10, 20 years, let's say 20 years from now, where do you think are we in the treatment of diabetes? What of all these avenues that we are pursuing, xenotransplantation, stem cell augmentation, bioengineering, encapsulation, what do you think is the future?
Well, I think there's no question cell therapy will become the preferred therapy of diabetes. And it is so clear to me because cell therapy works, and if it can be applied without the risk of immunosuppression like we seem to be able to do now, and if it is available on an unlimited basis, as it will happen because there is tremendous progress in manufacturing now fully functional beta cells, I think there is no question. And I think it is also clear to me because you cannot sell an IBM typewriter the day electronic word processing has become available, and patients will just not accept to be treated with entirely outdated technologies of the 80s and 90s. If cell therapy really shows it can be done, you can become diabetes-free, you can have a normal life, no longer compromised by constant fears and worries, and you can pursue a very active life, people will demand this, and there will be competition, and there will be more than one product available, and whether it will be this type of induced pluripotent stem cell or an embryonic stem cell derived, I think makes no difference. I think it will be cell therapy. I think the technology is there, and the next 10 years, you asked 10 or 20 years, I think we will see more clinical trials. I know ViaCyte has now started the second clinical trial, and this is all public information. You can look this up on clinicaltrials.government, and other groups in the field are gearing up to start clinical research maybe as early as this year. We will see tolerance studies. All of this will happen, and I think it will be an exciting time, and I think we are making the right decision by committing to this field and showing presence and prominence in the field, and by really being not only participants but advancing and leading this field as clinical investigators.
Dr. Pauline.
Oh, yeah, thank you. I think I'll do. I mean, I totally concur with Bernard, and I'm a pediatric endocrinologist, so I see a lot of children, of course, with type 1 diabetes, and I think CGM's pump technology, they've been great, and I think artificial pancreas technology is the short-term wave until cell therapy becomes more widely available. But I agree with the consensus of the patient satisfaction piece. I don't think if cell therapy is available that any patient is going to really want to be walking around with a sensor and an insulin pump on all the time, and then they have to worry about their pump site fails, or they're replacing their sensor, or they're going to the beach, and here they are wearing around two devices to act as a pancreas. I think people will want to move away from that. I also would say that at least with what we have now, we can't get as tight of glucose regulation with closed-loop pump technology as we can with cells. They do pretty well. They don't do the same thing.
Dr.
Yes.
Abukaloy.
I would like to quote what Bernard used to say 10 years ago. I think the patient population is very huge. Some patients will definitely require whole organ pancreas. Some will require islet allo. Someone will require pig islet xenotransplants, and some will require insulin therapy, because it's a very wide population. The needs are different in different population, I would say. But cell therapy will definitely predominantly will occupy.
Questions from the audience. I think we all are indebted to our patients, because a lot of the therapy that we are doing very often opens new avenues that have not been touched upon before. And we have to trust first and foremost our patients, that they entrust us with their lives and what we can do. We are, in the end, the guardians of their well-being. I think it's also important to mention that the word has to get out. I mean, it's a small group here, and there are even less people that know about islet or pancreas transplantation, whether auto or allo-transplantation, but it's not out there. And we have to do better in that regard. I think for our residents and medical students, this is really cutting edge that was presented today, particularly the last talk by Dr. Herring. Tolerance induction remains the holy grail in medicine. Whoever solves that problem as the egg of Columbus will receive the Nobel Prize, because it not only will induce tolerance, it will also solve the problem of autoimmunity, and will basically save all these lives that are being lost as a result of autoimmune diseases. Near normal glycemia, as the devices, artificial pancreas and so forth, provide, is not good enough. We know that. It will not stop the progression of secondary complications. They will continue to be a problem. Pancreas and islet transplantation are the only true cure at this point for diabetes mellitus. And for the next generation, I mean, you have to continue to think outside of the box. Like a David Sutherland, who in the 1970s decided to do living-related islet transplants, or introduced total pancreatectomy and islet autotransplant. This is important to think outside of the box, because in the end it will help to diminish human suffering. I think the Reverend John Williams is gone. He was here earlier. Brooklyn is really the capital of diabetes and end-stage renal disease in the United States. There is a symposium on diabetes going on this Saturday, and a number of speakers will be there, including our own Drs. Banerjee and Clifton Brown. This is going to be the next HPB Symposium for next year. I can guarantee you we will have another cutting-edge topic at that time. This fall, as you know, last year we had diversity in surgical cancer treatment. We will have a symposium on surgical treatment of patients that are in need of cardiothoracic procedures, and I have asked Dr. Poston to take the lead on this because we really will be a leader in robotic surgery in that regard. Finally, I want to thank Dr. Schwartzman and Dr. Renz and my support staff, because without them, this would not have been possible, and the sponsors for this meeting, because again, it would not have been possible to bring people from across the country to Downstate without the financial support. And I think this is the best way to end the meeting, by reinforcing the power of the social media and education for patients and physicians alike. Again, I would like to thank all of you for coming, and I wish, and I want to thank our speakers for coming to Brooklyn, and safe travels back. And we will have, as I said, our next HPB meeting in April of next year on the 23rd. Thanks again for coming.